crisis of tomorrow. And our final session is going to look at the fact that Europe is aging, and that has a huge demographic and societal shift. And we want to know, are we delivering enough? Have we prepared enough for an aging Europe, and what might this mean for our health systems? So that's our focus for today, and I'm delighted that to open, we have a message from the Minister of Health and the Deputy Prime Minister of Luxembourg to open our session. So let's watch the video message from the Minister.
Dear friends of Europe, while I'm unfortunately not able to join you in person, I'm very happy that I can nevertheless say a few words in support of your valuable efforts. The theme of your conference, Reimagining Health System, Green, Agile and Citizen-Centered, was very well chosen, and it hits the nail right on the head. So let me explain why I believe this is to be the case. The 21st century is marked by a number of trends with great consequences for our health. Climate change, aging populations and intensified globalization in trade, travel and migration are among the most crucial factors shaping the modern society, with a great impact on the human-animal-environmental interface as well as on public health. Climate change in particular poses a great threat to our health and well-being. Yet the healthcare sector in itself is a major contributor to greenhouse emissions and a source of pollution. It is crucial that we innovate and find ways to accelerate the green transition. The healthcare sector can lead the way as a field, making sure we meet our climate goals. Europe needs to take on a leading role and act as a trailblazer in this regard. New health technologies and green solutions need to be pushed and need to be adopted. All citizens will play an important role in this transition, as we are given more and more opportunities and also responsibilities to manage our own health through new technologies. These new technologies entail the production of valuable data holding great potential to better understand people's health, including those with rare diseases, and these new technologies also use this information to improve our understanding, to target prevention efforts, and to develop new treatments. Europe's population is aging, which will increasingly put pressure on our healthcare systems if we do not act now. We must increase our prevention efforts and health literacy to encourage a healthy lifestyle and reduce preventable and non-communicable diseases. We also have to make sure that our systems work as efficiently as possible, fostering effective multidisciplinary collaboration, both on the national level and across the European Union and even beyond. In addition, we need to address social determinants of health. Socioeconomic and demographic variables have been proven repeatedly to determine the health status of an individual. We must ensure health equity, and we must invest in the present in order to make sure that we all grow and age well. Challenges, but also great opportunities, lie ahead of us, and it is at forums such as this where we are able to share ideas, to coordinate our efforts and hold ourselves accountable for what we do, to innovate our healthcare systems and improve, in the end, public health. Let me congratulate the organizing team for putting together such an engaging and thought-provoking event, and let me all wish you very fruitful deliberations.
Thank you very much for that message from the Minister. So just to put the context for today, healthcare is constantly evolving, but in the last 2 years has had to accelerate the change. And part of what we've seen has been a shift out of healthcare institutions because we were unable to get to the healthcare institutions because of COVID. And that accelerated a change, a shift to telehealth, to people using more wearables, more various other tools to monitor themselves. People had pulse oximeters at home. So what we're seeing is an enormous change and a shift. But at the same time, we all became immersed not just in data, but misinformation. So here's the big challenge. For citizens to continue being strongly empowered actors and agents in their own health, we need to explore both the framework for data, how people can use it. We need to continue the shift in practices that we started at the beginning of the pandemic, and to see where we can build on that. So in this session, we're going to explore and take the issue of rare diseases, because if there's any area in healthcare where patients and their families have been forced to become real actors for change, it's in rare diseases. And in our session, we'll cover some of that to understand what of that gives lessons for the broader aspect of healthcare. Now, we are going to be using Slido to engage with you, so please make sure you've got your phones ready, because I will later be showing you the QR code for that, but I'm just giving you a note. We'll need your phones because we want to interact with you. But I'm delighted to start by turning to Stelios Kympouropoulos, who's a member of the European Parliament from the EPP group and also a well-known champion for health and particularly for rare diseases. So let me start by asking you, Stelios, what is Europe's role in supporting health systems that work for everyone?
First of all, I would like to thank you for this very important topic that we are discussing today, and I think that it's very optimistic to talk for health issues on a European level, and I'm glad that this is accelerated, as you told before, from COVID. And it's a very timely issue that we are in the time of discussing for a health union. So yes, we need to discuss again and again for the health. And regarding your question, as we all know, primary responsibility for health issues are not in the competence of union, but also are in the competence of member states. And the EU has many tools in order to support the strengthening of a health system, including policy statements, funding, information, and technical assistance. The COVID, as I said before, the COVID-19 pandemic has been a period of enormous disruption to health systems and far beyond, which has led to rethink our policy goals and objectives. This is a pivotal time for establishing EU support for health system with a new multi-annual financial framework and post-pandemic policy orientation emerging. And we need to stick on what happened with pandemic 19 because the European Commission made proposals for this so-called European Health Union, which includes specifically strengthened provisions for pandemic preparedness and response over the coming years. Therefore, we have EU for Health for the new financial period, 2021-2027, provisions for greater coordination at the European level in responding to cross-border threats. And we have expand from Commission side, but also from European, from Parliament side. We have expanded and strengthened the power of EMA and DCDC. And also we have created another tool, another office in order to create a better coordination among the different offices, and this is here. The COVID-19 pandemic has highlighted the need for the EU to have a rapid response capacity to enable to react to major health threats in a coordinated manner. And I think this is the core of all issues. We need coordination among member states. And I finish saying that the EU is supporting the health system in many ways, financially, politically, and socially. With the recently published European Care Strategy, it gives enhanced recommendations to the member states for personalized care. While with the Europe's Beating Cancer Plan, it encourages prevention, early diagnosis, treatment, and follow-up. I think that with the upcoming regulations, SOHO, EHDS and the revision of the pharma legislation, also medicinal products and pediatric products. The EU is aiming to address all the current gaps and ensure faster and better access to treatment. So I think that we are in the right moment for a holistic approach.
Thank you, Stelios. I mean, you've set out for us the way that the institutions have ramped up their capacity through agencies, through the upcoming raft of legislation. There's a reinforced budget for this time round, but we're about a year away from planning for the next European elections and the next mandate. As someone who represents citizens, when you go to them next time to ask for their votes, do you think Europe can meet the expectations of what citizens want from them? With everything you've just said, the greater mandates, the structures, are we able to meet the ambitions? Is that what citizens want?
I believe that everybody understands, any house understands that we need a center-based medicine and treatment. And the citizens have felt the need to increase the resilience and capacity of health system, especially during the pandemic, and how we need to take the lessons that we have learned from the pandemic and put them into the future, in a possible future crisis. Equal access to treatment, to increase, to have the lack, not to have lack of shortages, and lack of resources. These are the main things that in the European Union health we need as priorities. With its policy actions and plans, the EU can help address the medicine shortages and help balance geographical distribution of health workers, and can also offer an enhanced supply of critical medical products. Therefore, I believe that EDSS, European Data Health Space, can improve access to and strengthen primary health care, and providing easy, reliable data and exchange best practices among member states. I believe that we are close on what citizens want, and I'm very optimistic that we can accomplish their needs.
Thank you very much, Stelios. It's at this point in the agenda I'm going to be asking for your input, so phones at the ready, please. We're going to ask you a Slido question, and in a moment we'll be putting up on the screen the QR code, but you can go to slido.com, and the code for our conversation is 354491, or as I can see you all doing pointing, I feel a bit like being in a music concert. You're all pointing your phones, not at me, but at the screen. So it's 354491. And the question that we're going to be asking you is, we want to know what will be key to empowering citizens to take a bigger role in health. And we've given you a number of options, and you can choose several of them. Can I ask that you not click on all of them, but you choose 3, because otherwise the answer will be everything's important. But we want to get a sense, and remember we're in a context here looking at what Europe could deliver. We heard from Stelios that he's very optimistic, and he sees Europe putting in place the structures, the framework, the legal grounding that would allow some of the issues, but also the equal access to care. I know that last night we spoke about the challenges, particularly for Greece, meeting rural communities on small islands. So there's a huge expectation from citizens. So what would be your priorities to make a change in that? And so far, 61% of you are saying that actually it's change in practice by health professionals. Now that's a cultural shift, and I know we have speakers in the audience who might want to talk to that and respond to that. But also health literacy coming through now, that's a little more popular, 58%. So clearly the 2 winners there it's the population health literacy And I referred to the amount of misinformation that's out there on the internet. Last week, I was moderating an event for the European Commission, DG Justice. And one of the areas they were looking at is how do governments respond to influencers on social media promoting either banned products or taking products and promoting them for uses other than that of the manufacturer. And actually we had people from all around the world, from Peru, from Brazil, from India. This is a global challenge. So this issue of health literacy is absolutely key. But thank you for that. Funnily enough, access to the own data is so far not a particularly popular choice. So far only 20% are saying that that's going to be key to delivering change for our citizens. So we'll just close the poll there at that moment, and I may ask if we could freeze that. I will come back to that and ask for more. Now, our next speaker, Elina Drakvik from Sitra in Finland, they are leading the joint action called TEDAS, which is towards the European health data space. That's what it sounds describes. And this is where member states and stakeholders come together to try and put in place the building blocks of the European health data space. Now, I don't know if you were surprised by the fact that access to your own data was at the bottom of the list, which was a surprise to me. But what you've been talking to member states and stakeholders in this joint action. I know it's not finished yet, but what are your main takeaways so far?
Well, I have to comment also first on this poll a little bit.
Wait, we're just going to... Yes, it's
now
on.
It's on. Okay, yeah. Yes. I just wanted to very briefly comment on this poll as well. I think it was very good questions, but how I also pictured is that now we are getting already towards to better access for citizens of their health data. So maybe that's not the key anymore because we are going towards that direction. So what's next is really needed is this health literacy part and also changing the behavior and the whole how the healthcare system works, and the role of healthcare professionals is pushing and empowering patients more to being active agents of their own health. So maybe that is one explanation, but it will be very interesting to hear more from the audience who actually voted. What were your thoughts on this? But yes, to the question that you posed, so yes, we are positive. We have heard positive reactions from the member states on the broad lines, the broad terms in general. But there are, of course, a number of small details to be negotiated and to be tackled and to be clarified. And one of them is, of course, the sort of bigger picture on the legal clarity and also the complexity of the EHDS proposal as a whole, because it's not only EHDS, but it's also the Data Act, Data Governance Act, Artificial Intelligence Act, Cybersecurity Framework, and so forth. But it is indeed, as Stelios said, is the main building block of the European Health Union. So we are very much looking forward to getting there and to pushing it forward. And it will be an important step for the citizens, empowering citizens to have more control of their own health data and how they could be promoting that for their own health. In TEDA's work, we have a work package on citizen engagement, and the preliminary results from the questionnaires and the workshops that we have had with citizens in 3 different countries, in Belgium, in France, and in UK, is that citizens are willing to share health data, but of course with certain safeguards. So they want to know that it's safe, it's secure, it could be anonymized data, but also sometimes not, so it depends also on the purpose. But what citizens want to know is that they want to know where the data is used. So I guess there we still have some work to do. And then there are also some concerns on this privacy and security aspects and what could be the potential sanctions and penalties, and maybe these should be made more transparent also in the proposal.
Thank you, Elina. And let me just ask for a brief comment. We've got huge hopes for the EHDS. A lot of people are hoping this will transform our understanding of our health systems. It will transform health outcomes. So there's a lot of hope riding on that. As someone who's worked on it for a year or so, how hopeful are you that the EHDS will deliver what we want from it?
Well, of course, we have to be hopeful. But definitely, I am positive, but it doesn't come automatically. So we need a lot more work. We are just in the beginning of the journey. And we just also need to intensify all the actions. And one of the key issues is the capacity building and also the health literacy, but also the digital literacy, not only of citizens, but also of all the health workers. I can tell a short example because I work at Sitra, the Finnish Innovation Fund, and we also fund pilots and experiments. And we have one on digital therapies. We have different projects on digital therapies. And the first experiences that we have had from these pilot projects is that citizens are very much interested in engaging and using these new tools and technologies for the benefit of their health and managing their disease and to have better treatment and also the patient journey improvement. But it's clear that they need support for these digital tools, tech support. And this also goes for the health professionals. So they want to have support for using it. And it's very important to have the training as part of the introduction of these new digital tools. Okay. So I guess this is one of the key issues.
Right.
Yeah.
Thank you, and I'm sure as we talk a little bit more, one of the key elements is not just the training for the citizens and patients on how to use the tools, but it's that change in behaviour by professionals, including the skills and capacity for them to use the tools as well. Let me now bring in somebody else and it's Yann Le Cam, who's joining us remotely from Paris. Unfortunately, he was unable to travel because he wasn't feeling very well, but is well enough to join us. Thank you, Yann, for coming here. Now, I mentioned at the beginning that we're going to use rare diseases as an example of what it looks like when citizens and patients are empowered to be agents and leaders of change. So what can you tell us about that journey when patients have been forced to come forward and shape the agenda? How did that happen?
Good morning to everyone. Thank you, Tamsin. There could be several examples, and I will give two, but let me explain that maybe the way we work to help understand how we try to have that kind of impact is that as a community, we try to convey the needs and the experience of the people living with rare disease and their families based on evidence. So we believe in evidence-based advocacy toward evidence-based policy. And how we do that, we at the same time collect quantitatively the data, so quantitative surveys, and for that we have a tool, the Rare Barometer Voices, where there is now 20,000 families across Europe who are committed to provide data on different subjects. So they answer to quantitative surveys on a regular basis. And we had that, for instance, on the collection, use and reuse of health data for healthcare purpose and research purpose. But we also have qualitative methods of interviews, focus groups, Delphi methods, and other even more innovative methods of engagement of citizens for consultations. But we also use the testimonies, the videos, the written testimonies in order to bring to the surface really the reality of the people. And that is what we're trying to do all along in order to be real and connected to the diversity of situations also across Europe and according to the disease areas. That translates into some significant changes, I think game changers in terms of policy and services. In the pharma legislation, for instance, back 25 years ago, we pushed really with some member states in that period to have patients in the scientific committee of the orphan medicinal products. And this was the first time that in a regulatory agency in the world, there will be 3 patient representatives along the experts from the national regulatory agencies. And this positive experience then translated into similar patient engagement in scientific committees for pediatric medicines, for gene and cell therapy in the advanced therapy committee, but also in the pharmacovigilance committee, and now even in the preparation of the risk-benefit assessment in certain situations. And patients every month are going to scientific advice and protocol assistance of EMA. Really, Europe, with the European Medicine Agency, has led the way of patient engagement because of this type of experience, which was first initiated in HIV, but really was scaled up with rare diseases, and now across all health series. A second example is that when the cross-border healthcare directive was prepared, this patient community on rare diseases really advocated and tried to shape some of the key concepts, and particularly around the future European reference networks, which became, thanks to the work together between the community of people affected and clinicians, then to develop the 24 European reference network on rare diseases. And this, it's the same time, at the same time, the compass of what are the needs and experience and expectations of the persons living with the disease, but it's also always and always the collaboration with the interested parties, with the stakeholders, the clinicians, the hospital managers, the member states managing the healthcare system in that example. But maybe to conclude on the example on the European health data space, we've been very cautious at the beginning to say what the perspective of patients, because in fact there was no study really performed by the academia from that angle. So we waited to do the study that I mentioned before, a survey across Europe, in order to see what really want the people, what is their experience. And in fact, it was very clear. It's that it's overwhelming. Over 98% of them want to collect the data about their health, want to share it, and to share it for research and healthcare purpose, not only for their benefit, but for the benefit of all the people affected by their rare disease, or even broader by the society. So there is really an authentic generosity. But what they want is to be protected from the undue consequences. And that calls really for an ethical and secure manner on how the data are managed. And to do that, the patient voice into the policy shaping, but also into the governance after that of the systems and of the data is absolutely essential.
Thank you very much, Yann. Let me now turn to Maciej Gajewski from Alexion. We just heard from Yann how Europe was at the forefront of giving patients space and a role within regulatory agencies. Can you give us some insight from your side? How has the role of patients changed over time?
Thank you, Tamsin, and good morning, everyone. I think it's a really interesting case, the rare disease field, and Yann has already spoken about the examples of change making. I think the patient community or the broader rare disease community have really played two major roles, and the way we see this. I mean, one is really the change makers in terms of how the society has completely shifted on their understanding of the needs of the rare disease community, and what should be the responsibilities of our European societies in terms of supporting this important patient community, which, let's remember, just 20 years ago, I mean, was not really on the horizon at all. What we have achieved over the past 20 years, the level of mobilization, the level of awareness, the level of support and commitment is unprecedented almost. So, and this has mostly been because of the societal patient voice raising and really creating this significant change. And that change has not only led to the regulation, it has led to government rethinking of how to integrate a problem such as rare diseases into the healthcare systems, which was a difficult task. And I think we are evolving so much more into a system right now where rare diseases are not so much on the periphery of the system, but are becoming a standard element of the healthcare system. And hopefully this is going to be even more so in the future. So this is amazing. But I think from the company perspective, and Alexion has been in the space of rare diseases from its inception 30 years ago, I have to say that from the company perspective, the patient role and the patient voice is also important in terms of driving innovation. This is an absolutely incredible source of not just inspiration for companies, but perspectives, insights, and data that the companies work on to advance their innovation. So Yann mentioned the evidence-based approach from the patient community. This is so critical. We within the companies, we rely on this evidence, we rely on those perspectives to research, to start with, to understand diseases which we want to try to address with our future solutions, then to design trials and actually make them designed in a way that actually respond to or address some of the key challenges that patient community has in relevant disease areas. And it's not very straightforward because there's a lot of, let's say, innovative approaches that is needed to do this. But then it goes even further. I mean, understanding the patient journey and really the every element, every step of that patient journey in every disease is full of very relevant information that we as the companies try to co-create together with the patient community to design the solutions that will actually be the ones that help. So it's not just the products, but it's all sorts of services that you can build and develop to support the needs of the patients which are very special. So I think we have been moving from over the past 20 years or so from a system where, okay, there was we always have been close, but now this co-creation and collaboration between the patient community or broader rare disease community and the industry has really intensified for very, very good reasons, and I think rendering amazing outcomes for the entire community. So this is the time, I think. We've never had this. I mean, this is so promising, and it's with the science and technology catching up or even advancing faster than that. I think that that field will see amazing opportunities in the future.
Thank you, Maciej, to describe to us just how revolutionary the change has been in the last 20 years. And I know that the rare disease community want to continue that momentum in the next mandate by getting a strategy at European level on rare diseases. I'm now going to open the floor to questions or comments on what you've just heard. And remember, what we're trying to do is explore how citizens and patients can be empowered and play a greater role. We'll get you a microphone, and if you could just briefly introduce, say where you're from.
Can I make a
Yes, of course, Stelios, you're welcome.
Yes, and thank you very much that you referred to that we need also, along with the pharma and the treatments, we need services, because the disease is also a social issue. It's not a medical issue that we need also just to treat, but we need to create an environment which supports each individual. And this is, I think, the revolution that we need to create in the future in order to build a very concrete European Health Union. We need also to build a very good and parallel social social foundations in order to support our citizens and our Europeans. This is my comment, and I think that we need to reconsider whenever we talk about treatment and whenever we talk about rare disease patients.
Thank you, Stelios. I think one of the red threads that will go through our conversation in the 3 sessions today is looking at how the patient, the citizen, becomes the point of care. And I know that's one of the recommendations that came out of our working group on the European health data space and rare diseases, where you participated and helped to come up with that. We're going to be talking about that societal shift in the way we address healthcare, and that health is something that is not something done to you in an institution, but is more an interactive continuum that surrounds the individual wherever they are in the different aspects of their life, including social care and other services. Yes, please.
Thank you so much.
If you stand up, please, so we can see which microphone it is. Go ahead.
Very good. Good morning, everyone. My name is Magda Krakowiak. I'm Director of Business Creation in EAT Health. I just wanted to, let's say, patient engagement and citizen engagement in innovation. This is something what we have been trying to do for, let's say, since our inception in 2016, and many of our colleagues, they have spent their careers trying to do that. But before we get this kind of feel good, feeling around that now patients will be involved, they will be sitting in different boards, making decisions and choosing what is right for them and so on. I wanted to essentially plea to everyone to really think how we do it. So it's not only about having a citizen or a patient deciding about, let's say, possible treatments or saying what kind of innovation or where the innovation should be going, but it's about the right way of engaging patients. And here I'm let's say sharing a little bit of a frustration, because we have been trying to do it right, and every time we go through lessons learned and we say, okay, so this time for sure it's going to work. It's not necessarily the case. So having patients involved is very, very important, but they have to be involved in the process in the right way.
Okay.
Okay, so this is definitely a good change, for patient not to be a subject, object, but to be a subject and to be part of the conversation.
Mm-hmm.
But if this is not done right, then I think we might be risking causing more damage.
Thank you.
Than not having patients involved.
Thank you. And I think that's something I might invite Yann to respond on, because obviously they have quite a lot of experience. Let me also see if we've got some other inputs from the floor at the same time that I could put to our panel. Does anyone else want to make a comment or ask a question? I see Elina will also want to come in. Yes, Kieran, if we could get a microphone here, it's just to your side there.
No, thank you. It's just to agree wholeheartedly with Yann. Having been involved in the British system around sharing data and chairing an advisory board to try and dig us out of a hole, one of the major lessons was you can only get consensus on the right way forward when you have the patient organisations, the privacy group, the clinical organisations and the regulators in the room at the same time. It's not enough to have binary conversations, because the co-creation doesn't take place and somebody's interests will be written over. And I think we need to be really careful that the uses that people will be putting the data to have really been thought through, because things which came as surprises to particularly the privacy lobby, but also the patient lobby, almost derailed the whole project. So I think the design of the process of engagement is almost the most important thing.
Thank you. And Elina, I saw you nodding on that. Maybe you want to comment on that. And Yann, I'll bring you in on this as well. But Elina, go ahead.
Yeah, I just want to briefly comment what Magda and Kieran just said, because I fully agree. And often we are only asking when something is already out there and not in the process and in the design phase, or even in the ideation phase when we are starting to brainstorm with the ideas. And I think we should start definitely much earlier and bring citizens and patient involvement. It will be crucial also in the EHDS and their trust, and if it's working for them. So definitely we have to pay more attention. But it is also a cultural shift among the healthcare workers. So it's not enough that we focus on citizens. It's not enough we focus on healthcare professionals. We have to work on several fronts and include the different stakeholder views. Also the researchers and how crucial role they will play in EHDS. So there will be a lot of different views around the table, but it's also essential.
Thank you. Yann, let me bring you in on this, because we heard from Magda that it's hard to involve citizens and patients in innovation methods, and she keeps trying, keeps failing. And I suppose one message would be keep trying. There is no perfect solution. But we also heard from Kieran about the importance of everyone being in the room at the same time and making it a sort of rounded conversation rather than separate conversations. Do you have an example, Yann, of where you consider that we've really got it right in terms of bringing patients and citizens involved in that innovation cycle?
I think so, and I think that surely it's not easy. Surely it varies to context, but there is a lot that can really be learned from the experience, but also from joint projects which have delivered best practices. And there is also plenty of documents to guide these good practices now, and also trainings. So you can start by your website, but there was also different website that we could refer you to. I think the patient engagement really is taking place at different moment along the patient journey now. So I mentioned previously the European Funds networks, but it's not only about being involved into the board of a network, it's about being involved into the working groups on diagnostic or newborn screening, in the registry, or in the guideline on good medical practice, or it's about precisely a working group on the patient journey in the healthcare system. So all that kind of activities are helping to bring really the patient voice at the right place. The challenges are always obviously to identify the persons who are able to do that. It's not easy, but also to provide the right support for it. So that's about training. The training doesn't always mean a full week. It can be very short, but adapted to the circumstances. The clarity, the first clarity that's needed is the why. And often there is confusion here. It's often a tick the box exercise to have the patients involved now. And it has to be more than that, and to be more authentic. I can take the example of the European Medicine Agency, which I mentioned before. And here, over the time, we have really collectively, together, between the patient community, particularly in the field of rare disease, but with the European Medicine Agency, developed the right way to do it. So how to identify a patient which is able to make a contribution because he or she understands what is the exercise, but also because the institution, the committee in question, or the procedure in question, are ready to accept the comments that will be made on certain elements in the discussion, so that then it's a real dialogue, there is a real co-constructions. If not, there is no value to bring a patient like that. Training is essential, but to have also staff support in the European Medicine Agency and in the patient groups to make it happen in the proper way is essential. If we leave it to random or just matchmaking electronic contact, that just doesn't work. It's a failure. And as important also is the management of the potential competing interest, which are very important, both for medical experts, but also for patient representatives. And I think now we've learned really how to do it well, and it works without any major problem over the last 20 years.
Thank you, Yann. Maciej, I know you wanted to make a comment.
Maybe just two more words to this. I think, from a research-based company perspective, I think it's about very important shift. It's a shift from typically environment in which scientists and clinicians have been running the research and you know, they have been considered as the gods of knowledge, right? But I think in rare disease space we have very quickly learned that, you know, there is so much expertise and so much knowledge that actually is not with the physicians and clinicians and scientists, but actually with the patients themselves, their families, and that without understanding those perspectives thoroughly, you cannot design a proper trial or develop a proper solution or intervention. So it does require a significant either shift or actually a DNA of an organization programmed in a way that there's always that patient voice and there's always that patient centricity in the very center of our thinking. I think it's crucial. Otherwise, it's always going to be a challenge. So it has to start from the beginning.
Thank you. Stelios.
Yes, I totally agree with Maciej. We need patients in order to show us the direction. And then we will, from any point of this direction, we will fill the gap, even if political, scientific, research, whatever. But I think that patients need to be in the core of this procedure because we have lost many times the direction, and we want the civil society, whatever is this kind of civil society, to tell us, go there, because this is what I need in my daily life. This is I want as a priority, and I think that all together, sitting on the same table, we can feel this direction and we can follow the need of the people.
Thank you. Elina, I'm going to come back to you on an issue because we've been talking very much about health data spaces, but that's just one of multiple data platforms that the European Commission is putting forward. And when we talk about the citizen and the patient going about their daily life, we need environmental data, we need urban data, we need socioeconomic data, and all of that put together helps to build a picture of what's going on. So perhaps you could just make a comment about, you know, the shift to digitization, which isn't just about health, it's about a number of different areas, including public services and use of that. How is the EHDS going to interact with these other data spaces that are being put on the table?
Indeed, very important question. I'm not sure if I have the answer how exactly, but indeed the Commission proposed already in 2020 the European data strategy. And in this data strategy, it's not only the health data space, but also 8 other data spaces, one on business and industry, transport, agriculture, Green Deal, and of course in this context the Green Deal data space will be highly important if we are looking at the environmental determinants of health. So looking at biodiversity, looking at food systems, looking at the chemicals and the exposures. So with the digital tools and the wearables and the sensors and also with the help of environmental monitoring, we are getting a better grip what we are exposed to and what are the risks, how we can reduce those risks, what are the hotspots, where should we focus on. So in this sense, we have huge opportunities, but it of course also comes down to the data and how we'll be able in the end to use it as citizens, but also as researchers. There are very good examples already how you can already monitor as a citizens your local environmental air pollution. There are different kind of portable devices. We have the wearables that you can monitor your health. So what we would really need is to combine this data and make it interoperable, but then also to have someone and the clever apps and the software to interpret that.
Thank you. Let me open the floor if anyone wants to make a question or a comment from the floor. We're touching here on the role of digitization as part of the societal shift that we've been talking about, and this interesting point that, you know, connecting in the health data space with other data is really important. I mean, every aspect of our life, you know, the monitoring the air pollution that's outside, monitoring transport use so that public services can be put in place, monitoring who needs what social care, it all is based on data, and we need to make sure that that information is taken into account so that patients don't just have a role in healthcare systems, but also into broader society. We have a question over there. If you could stand up so I could see you and just introduce yourself and go ahead.
Good morning, Jane Barrett from the International Federation on Ageing, and thank you to all the speakers. 2 questions. 46% of the world's population are not connected. How do we deal with that? And secondly, none of us in any country of the world is very good at collecting age disaggregated data. And this is one of the burning issues of our time, isn't it? How do we deal with that?
Thank you, Jane. You have indeed put some challenges for us, and I know we will touch on that a little bit later. But let me, who would like to pick up on this first? Maybe Elina, I'm going to start with you, because on this issue of disaggregated data, you're sitting there with member states and stakeholders. To what extent are people looking not just at data collection, but disaggregating data on gender, on age, on ethnicity, so that we can start to understand the hidden patterns of discrimination or access that we need to address?
Yeah, that's a very good question and very important, of course. And in research, sometimes it's forgotten the sex and the gender data, and we focus only on some of the aspects. But it's getting more and more attention. So definitely these are discussed because it's meaningful data for our health. Regarding the connectivity issue, I fully agree. I was just a few weeks ago in the World Health Summit, where the discussions are slightly different compared with the European ones, because it comes a lot up to the lack of access, not only in terms of the sort of internet and digitalization access, but real lack of access to any kind of healthcare system, any kind of health services. So yeah, we can develop also some services if we think about technologies and the digitalization, that you don't have to be online all the time, but you can then upload the data sometime when you are more in the sort of area where that is possible. There are some platforms and tools for that already existing, but these are very rare. Some are more focused on sort of mobile health type of applications and tools. But that's a huge challenge, and it's definitely important to keep attention also to this question and find the answers.
Thank you, Elina. And I'm going to come to you in a moment, Stelios, as well, to respond on that. But just let me highlight that the European Commission's own data shows that we have between 25 and 30% of our population that lack functional literacy, whether that's classical literacy or digital literacy. So even within the EU, we have challenges. We may have our high penetration of mobile phones, but that doesn't mean that everyone has the capacity to use it. And my mother is 80, and I had to spend some time with her this summer helping her, because in order to interact with the Commune of Brussels, you need an app. In order to prove your identity, you have to have the It's Me app. In order to have your COVID vaccination, you needed that something on the phone, without which you couldn't access anything. And I spent quite a lot of time helping her to understand that. And to the point that I replaced both of our phones, so we have exactly the same model, so that if she had an issue, I could talk her through it because I would know what to do. It got to that point that I needed to do that. So Stelios, I know this is an interest for you, particularly coming from Greece, where you've got small islands and rural populations. So some of this challenge of lack of infrastructure and then lack of capacity or literacy to use all of these things. What would you like to share?
Yes, I think that the aging is not the obstacle. The thing is, because I'm afraid that even if we have young generation, sometimes they don't know how to use in the right way in order to do all these things. Yes, they can go into It's Me app application, but after that, what's happening? And this is the thing that we need to show and to raise the awareness and educate the right use of digital everything. It's because we are living in the digital era, and we need to be on the position that we know what we have on our heads, on our hands, because this tool could be a knife. A knife can cut or can kill. So I think that because we are at the moment that because we are building up this digital, because we are still in the process, we need to show the right process. And I think I want to say something about 46% of lack of having access. Therefore, we are here as stakeholders and policy makers in order to show that everybody needs this access, not only on European level, but also worldwide and third countries. Therefore, I think that we need, from our opinions, our text, we know to show that on this era is the right for someone to have access to digital epoch. I think this is my opinion, and I believe that we will face in the future more and more.
Thank you. Maciej.
I'm not an expert in this, but maybe just I can add one or two perspectives on this. I mean, first, I think we should be optimistic about the prospects. There are more mobile phones than people right now on this planet, and probably this tells us a lot about the future designs that need to be driven in healthcare maybe it's completely different platforms that we should be using. Just one, maybe provocative food for thought, but I mean, I've seen those examples in as some business cases now explained to different organizations. When we look at what's happening in China with one app, which is called WeChat, they operate everything from the one app, including all of the healthcare appointments, all of the health data that they have available for one app. I think that's probably a very significant change between what we have in Europe with you know, a huge number of apps everyone needs to navigate. Maybe it's not the simplest way of doing things. So there's probably some food for thought for the future, but definitely the platforms, the fact that everyone has mobile phone these days pretty much, and even more than one, that's probably creating so much more opportunity than problems, and really, I mean, more than ever before. So that's the call for optimism.
Thank you. Yann, can I bring you back in on this one? Because, you know, we're talking here about inclusion and making sure that we have the data that gives us the information, whether it's disaggregated on age or anything else. For rare disease patients, not only are they having to navigate a complex health system to try and get a diagnosis, and we know that that diagnosis journey can be very long, but also now we're expecting rare disease patients or other patients to then become experts in digital tools and to link all of these different processes. You know, how much of a barrier or a facilitator do you see digital tools for citizens to become more active in the future?
I don't know really how much a barrier that will become when you see what most people are able to do with their mobile phone today. So I recognize that there might be parts of the population either linked to age for the most aged persons, but or lack of general literacy that may struggle with it. But when we look at what people are able to do today with their apps on their phone, I think they should be able to do that properly. It's a matter on how the tools are being developed so to be friendly to the persons or to the patients. Then in the case of diseases like rare disease and other chronic disease, it's a bit different because your health literacy increases. You are more knowledgeable about your disease. You're more knowledgeable about what is important. You're being briefed potentially by your doctor about what's important also, and you have your community where you can refer to and the social media where you can refer to. So I'm not sure that's going to be such a barrier in our case. I think in our case what we have more is still some of the basics of the awareness of what are the signs that it may be a rare disease in order to speed up access to diagnosis. But after that, using an app, for instance, to enter some of the symptoms that you observe as a parent, as a grandparent, as a brother and sister, and to progressively refine, could that be a rare disease in this type of therapeutic areas and be oriented to the right specialist or the potential centers? That I don't. From our experience today, we don't see a major health literacy issue here. I think it's really what we do with the tools. And you mentioned at the beginning, Tamsin, the huge changes due to COVID. Yes, that's true, and we have communicated about it. The use particularly of more telemedicines for consultations or for renewal of prescriptions or for therapeutic education. But I'm really worried about how fast we're going back to the previous world, and how little we're learning from all these experiences. The system is very conservative and resistant, not only resilient. And for instance, we are not taking advantage of the fact that thanks to telemedicine, it's now possible to have your pediatrician or your family doctor participating to the meeting with your hospital doctor in order to have a better follow-up and a renewal of prescriptions and maybe a better reporting of an issue, rather than leaving us every time on a one-to-one in different discussions. So we are not building, because then it's complicated. How do you get the doctor being reimbursed? How do you organize all that? So it's more for me a resistance of the system than a lack of health literacy. I'm not ignoring the health literacy issue in general, but I think it starts much before the questions of data. Then it's all about education and how we leverage overall the media, but also school to educate people about prevention and reducing their risk over their lifetime. That will be, in terms of healthcare impact for me, a much higher impact than really looking only on the capacity of using digital tools.
Thank you, Yann. Just before I pass to Andrzej Rees to close us, I'd like to invite a quick message from, we're delighted to have the Serving Minister of Health from Latvia here in the audience, Daniels Pavluk. Please go ahead.
Yeah. Thank you, Tamsin, and thank you everyone here on the panel. Is there any way we can bring Slido back? I was wondering if you're going to do this.
You want to see the slide? That
Yeah.
we did? Yes, we can put them up on screen.
Just in light of what Maciej has been talking about, and Yann actually.
The results of that slide,
Yes,
there we go.
yes. We have this session called What Will Be the Key to Empowering Citizens? And in fact, of course, this is a question of what came first, chicken or the egg? But it seems that this expert audience has come up with the unanimous answer that it's an egg or chicken. I don't know which, but one or the other. Yeah. So while in fact it's both. And it seems we do not really trust the citizens in, getting empowered and doing things on their own, if we look at the results of the poll. And I think that we're misleading ourselves. We still think that the locus of control is with us the doctors, us the educators, while in fact the digital disruption, digitization of various industries has shown the opposite. The technology enables us to do things we never thought were possible, and then the experts and specialists need to adapt and catch up fast. So I think we're misleading ourselves a little bit here, and we should be open to possibility that things might not go the way we expect. Thank you.
Thank you very much for that, and again, very thought-provoking. I'm going to invite Andrzej Rees, who's the Chief Scientific Officer and Advisor in DG SANTE, just to reflect on what you've just heard. And if I can invite you to look forward. As I said, we're a year away from the big institutional game of musical chairs, when we'll have new members of the European Parliament, new European Commission. What are our hopes? What should we be passing to them on their to-do list and their already accomplished list?
Okay, good morning, everybody. So I am in this new role since a few weeks. So I used to be for more than 16 years, regulating, pushing, managing policy development and regulation. But let me start from, I will try to, I got 5 minutes. I will stick to the 5 minutes. So I will start from this very, very beautiful questions, citizens, consumer, patients. Because, we really are in this I don't know, you said chicken and egg, this is the quite complex issue, because one day we are citizens, putting our votes, for our beautiful future parliamentarians. Other day we are consumers, because we have so many choices today, many of them, healthy driven. And finally, we are patients when we start to exercise, like happened also to me in my current life. So this is the first things I think we should keep in mind in this whole debate. From voting, our rights, also rights to get access to internet. In the report we made, a few months ago, published in Lancet, from the Commission on Future Digital 2030, we're saying this is like a human rights today, access to the net. So I think we really, as a citizens, we have to make this happen. New technologies is a challenge, and I fully agree with this disruptive way technologies are happening. I think this is the huge challenge for all of us, because this is how we are going to build the future. It very much depends, on this disruptive idea. I think Yann said something which I agree about, this kind of fight with the conservative system we are dealing with. Usually I ask question in audience, what do you like, to be operated by a conservative or innovative surgeon? And I can tell you, when you get this question, half the decision is half-half, because, some of us would like to take the risk, get for innovation, others prefer to be in this conservative setup. But for sure, disruptive of technology is coming. Data, I think this will continue to be the big debate for many reasons. We are moving from this my data to the ours data. So I think what was said about the future, we continue to have very interesting questions about the implementation of hopefully agreed European health data space. This is a huge effort ahead of us. So I will now say a few words about because we have important legislative agenda going on in the European Parliament and in the Council. We have European data space, we have substance of human origins, we have hopefully pharma coming soon. So there will be a package of things to be implemented. The implementation is more difficult than even developing of new legislation. Tobacco is now under evaluation, important, again, regulatory issues for the future. We have to build on health security, because I think citizens will not forget what's happened with the COVID. And I think we, as was said, in the beginning, this agenda around health security should be stabilized, should be explained to citizens, because I think most probably, of course, the human memory is vanishing very quick, but I think that we know that frankly speaking, when I finished my journey with H1N1 pandemics, I said it's enough for my period in the Commission. It came, with COVID. So I think we have to be ready for next. Whole debate around health literacy, I think it will continue, and I think what is also, as we also have seen from our voting, the role of health professionals and the role of patients and the interactions. And COVID showed that I recently spoke to pharmacists, and they started to do the vaccination, which was not imaginable for many. They started to do testing, but what's happened? We all know how to do swab and do antigen tests. It was unimaginable, 3 years ago. So there are new roles we can find in the system and do better. And now I think it's important, I'll try to conclude, something we discuss around the rare diseases and the community of practice and all these developments done around this. I think it is an excellent model to be also developed, continue to be stabilized, and also show to others, because I think this, I fully agree with all speakers, that we created something which is very unique, but I think we should harvest more from this, from the system. And the last point is on this cross-sectoral issues. The data should be used, in the benefit of our individual choices, but also our treatments, our ability to develop new products, but also assess them. And somehow, I think this journey with data will be continued, because they will help us hopefully to find also common language of working together. So I am optimistic. I believe this is what Maciej said, that we can do more. We are coming to the new era. Of course, we should not forget about this big security issue just next border to us, because this, of course, will not vanish very quick. Thank you.
Thank you very much, Andrzej. And can I say a warm thank you to the members of our panel, to Elina, to Maciej, to Yann, and to Stelios. And I'm now going to offer you the coffee break, and that will be downstairs. When we come back, and we'll start at 11 o'clock, we're going to have a fantastic intervention by Lubna Bouafra, who is a pioneer in the use of AI in health systems. So we're going to tackle some of the issues we talked about and hear how that potential could be realized. So thank you to our panel, and see you after the coffee break.
Recording stopped. Recording in progress.
Welcome back, everybody, and thank you. We've just noticed that Lubna and I have subconsciously chosen green as our theme, and our next speaker as well has also got green, so we are leading at the green transition for health, even starting with we're walking the talk, we're wearing the talk. So I promised before the break that we would hear from Lubna Bouafra, who is the founder and CEO of Okra Technologies, which is a leading award-winning artificial intelligence analytics company in the area of life sciences. And for Friends of Europe, she's a member of our European Young Leaders Network. I've had the pleasure of talking to Lubna and hearing her speak many times over the past years, and she has a truly visionary, clear sense of how AI is a tool that supports us in change rather than what perhaps people fear, which is that it would control. And we invited Lubna to come in and set out a vision really about how we put the human in the center of AI for health. So Lubna, the floor is yours.
Thank you, Tamsin. Hi everyone. It's a pleasure to be here with you today. So we heard in the first panel, and please, if you can share my slides, I think that's waiting for the team to get it. Great. So we've heard in the first session how we need to put the patients in the center, from their experience in the healthcare system, from their opinion in the ideation, in the design phases of any product into healthcare. What I'm going to share with you today, how we are bringing the patients in the center through their data. So if you look to our world today, I was born in 1983. Back then, the world population was about 4.7 billion people. So today, or last week or 2 weeks ago, we reached 8 billion people on this planet. All of these people, all of us, our data is already used. We've heard from Andrzej, there is a consumer in us, there is a patient in us, and there is a citizen in us. Both the consumer and the citizens, our data is streaming everywhere. When we buy things, when we visit shops, everywhere we go, when we use transport. But the patients in us, so our data is used only when it's necessary. So how can we change that? Since 1983, many things changed in our world, but healthcare didn't change that much in terms of workflow. We still wait for people to get sick to help them. And today, the healthcare sector, after the pandemic, we are facing great challenges in terms of capacity, in terms of dealing. How are we going to keep 10 billion people healthy by 2050? And the commitment we have on CO2 with getting zero carbon. So how are we going to get all these goals? How can AI and data help us get there? So outliers is the story of healthcare. One of the main barriers for healthcare that we are seeing people as averages is a mathematical theorem called the central limit theorem. There is, of course, the bureaucracy that dominates the healthcare, but there is one formula in mathematics which I love so much, that it tells if we take a few samples that are randomized and biased, we can fit in a nice bell curve, a Gaussian distribution, and generalize the results, which is fantastic when we can apply that. But in healthcare, we can never get to that level of uncorrelation. Not only that all our organs are correlated, but also we are sharing the same environment in terms of pollution, societal impact. All of that makes us very correlated human beings. So to apply the central limit theorem, to apply that we can generalize treatments across population, and the gold standards for validating treatments is clinical trials, is applying this theorem to validate treatments and assume it works for everyone. It's not realistic. We've done it and we keep doing it. We keep calling it gold standards, but today we have the technology that is truly gold standard. If we look to this distribution, the tiles of it is the majority. Most likely you and me will be in those tiles of this distribution, which means it won't work for us. So how can we move to the tiles of the distribution where the majority of us lie? And that is the technology of AI. AI leverages these algorithms to bring together different data sets, from health data to environmental data to societal data all together to predict what is the best outcome, what is the best treatment for these patients. Taking also lifestyle data, which is very important, how mobile this person, in which environment, and how can we get the better treatment. And that's where we need to move. So when we talk about AI, the father of AI is Alan Turing. AI doesn't need to pass the Turing test for healthcare, which means it doesn't need to outperform humans. It's taken a different role than humans here. So AI is very good in analyzing a huge amount of data historically to come up with a prediction. It's a very good tool to predict. It's a very good tool in an industry that is evidence-based, which means in healthcare, we use the past to predict what is the best treatment and the best action for this patient. So in healthcare, AI doesn't need to pass the Turing test. AI is taking a different role. It's similar to the aerospace industry. Airplanes didn't need to fly like birds. It had to be designed to respect the aerodynamics laws to fly under this engineering condition. So I believe we should treat AI like engineering, to deploy AI systems where there is the need for this, remembering all the history, identifying the best treatment possible, identifying to which course we need to follow, rather than try to mimic what humans already do. So which tasks do we see in healthcare? So we already see huge tasks that are ready and ripe for automation. Think about patient triage. So we can deploy AI solution to early in the process, triage patients to different courses, to serious cases, routine cases, to free up the time for the medical teams, from nurses to doctors, to focus on what really matters. We can deploy AI in processing low-level data, which is around imaging, around scans, where there is high capability to be able to detect tumors and to detect nodules very, very accurately than humans. So there is a huge potential to include these solutions across the point of care and to have a central way that can pass and continuous testing of those systems and the accuracy of those systems and bringing the speed and the accuracy into our healthcare system. We already have, in research, proved that AI achieved high level of accuracy to be deployed in the clinical settings, in dermatology, in ophthalmology, in radiology, in so many applications. But why is it not there? So the barriers are not the tech or the data, even in this case, the barrier is to get it to the clinical practice. So why the time is now? We are all at inflection point, not just in healthcare. In every industry, we are at this inflection point. We just passed through the world's largest pandemic and now entered into a war, and all the world changed overnight. And in healthcare, what did it mean for us? We see that we could validate the vaccines within 10 months instead of 10 years. We could bring the speed into the clinical trial process. We could bring the speed of bringing these new treatments faster to patients. And we are at this point where we see the capacity of our healthcare system is getting under pressure. So the time is now to really leverage the data and to adopt, to bring not only the safety and the effectiveness of treatments, but also the efficiency. And that is the moment is now, and therefore we need to make that decision and to make that transition faster. We discussed yesterday, what if we don't? If we don't, we know what is going to happen. If we don't, we know that there are already big platforms reaching very large population of consumers. They're not going to go to the patient. They're going to go to the consumer who wants a fast service, speedy service. They want not to waste time waiting for a GP appointment. They want just to be alerted and treated like a client. So adopting those services when they are available from a big tech platform will be the easy option for this new generation. So we really need, if we want to keep protecting our healthcare system as we know it, we need to make that transition to start leveraging the data from health data, from environmental, from societal, to predict and to prevent and to support the patient and not the consumer. So let's imagine, what health do we want by 2050 when the population is about 10 billion people? We want a healthcare system that from birth, childbirth, we already have a data to start with, predicting the risk for potential rare diseases prior to birth, already preparing the parents to how to care for this child. And during birth, already we start scanning from genomic data to all scans to be predicting. And as we move along, our data is speaking for our needs as patients. It's driving our healthcare system. Imagine this data-driven system, that the fuel of this system is data streaming from every one of us, that all of our data is helping millions of other patients because we have similarities in that aspect of our human body. So when in one of my talks, one of the people in the audience asked me, well, I'd like to be part of it, but can I opt out from sharing my data? So just imagine being part of this system. You are using everyone's data to get a better treatment for yourself and to prevent yourself from getting sick, and then you decide to not share your data. How ethical is that? It's just like wanting to get an organ from other donors, but you don't want to be a donor yourself. I believe ethics is a double-edged sword. It's not only ethics towards the technology and towards our rights as citizens, but also ethics around how we participate in this era of the fourth industrial revolution, where the fuel of the economy to drive it to be outcome-driven is our data themselves. Why we are sharing our data with all these entertainment platforms, but when it comes to health, it becomes a taboo, and it's my data. So I think we really have to rethink the way we see this. And we have to position it differently from patients to consumer to citizen, especially when our competitiveness and our health standards, healthcare system standards will be at the level of the quality of the data we train it with. So data is the new fuel. There was some discussion yesterday that whether that's the right thing to say, whether data is the new currency. Well, in this shift from an economy that was volume-driven, with selling more products as a volume, to an economy that is outcome-driven, we do need data. Without data, we cannot make that shift. Not only we have to make it, because of the world population is plateauing by 2100, that we will not have the growth, the exponential growth of the population. So every economy is moving from a volume-based to outcome-based to make more profit. But in this specific industry, we are evidence-driven. So we should be outcome-driven from the beginning. But because of the history, we have been focused on this specialization or clinical-driven healthcare. At this time, in order to move to the outcome-driven healthcare, we need that data to be able to predict what works, what doesn't work, what is the risk. Without it, we will still be paying for the pill instead of getting better. And that is the shift that we need to move, and that's why data is the fuel of this transition. So data sharing, as I mentioned, is a key element for this. And in order for our healthcare system to be 100% holistic and to be patient-focused and patient-centric, not only from an experience level as patient, but also from the data level, from the environment level, from the societal level, we need all this data to be deployed, to be supporting our healthcare system, the different patient pathways, the different prescription of treatments, and also marrying together the outcomes and the costs, that we can predict what is our budgets here, what treatments can we afford, and how to drive it together. And not only that, we not only have health outcomes, we also have carbon outcomes and societal outcomes, we can bring this together. At OCRA, for example, we are evaluating the different treatments, not only on their clinical outcomes, but also treatments that require a visit to hospital. They have higher carbon footprint. So we will need to manage multiple outcomes and orchestrate the decision based on that. And that is the role of our governments and our healthcare system. How can we reflect that in the way we interact with patients? That brings me to the ambition on the European healthcare data space. We have, as entrepreneur and AI scientists, I have big hope that the European data space will be the catalyst to move to this data-driven healthcare system. When I a few years back, when I started exploring, and I was part of the high-level expert group and looking into the European health data space, I realized it was a summary. It was aggregated summary. We cannot use a summary to train AI. We need granular data on a patient level, standardized, and at the right level of granularity to be able to deploy AI systems to predict outcomes and to be able to productize it in a proper environment. So when I hear the discussions about the European health data space, I am very excited, and I'm thinking there is a huge opportunity if we get the engineering parameters right, the right granularity levels, the right covariates, because we also saw the experience in the US because the data there is already collected. Sometimes key parameters, for example, for oncology, like the ECOG, or they are not collected properly. So how can we make sure that the right variables are in there? We have the opportunity to build it here. And last but not least, it needs to be shared with the right stakeholders. At the moment, I only hear around healthcare providers and academia. Well, we know what is the incentives there. Academia is incentivized to publish results in good journals. That doesn't mean it can get it to the level of productization and level of deployment and industrializations to serve the patients at the point of care. So in order to do that, we have to rethink. And we can use positive discrimination, it's been said yesterday, to choose the right companies that will help this transition to data-driven healthcare systems across our member states. So I will say, just like my previous speakers, that I'm very optimistic about the course and the decisions that we are making. We are at this inflection point, and we have good values. So the ingredients for the good AI is not only the data, it's also the outcomes. We know from the different continents in the world, Europe is focused on the right values for citizens and for patients, and we know other continents are more around driving the competitiveness. We see how AI is used to drive more ads and to sell more products. We have here the advantage that we can define the right outcomes for our AI to drive the patient's outcomes to drive sustainable outcomes combined together with patient's outcomes. So we have a huge opportunity because we can control those outcomes where we train our AI from. What we need is really the data and to the right granularity level and to the right stakeholders to get to that future of data-driven healthcare systems that prevent people from getting sick in the first place and help us get into integrated and standardized healthcare system across Europe. Whether you are moving from one member state to another, your data is speaking for you and is helping other patients to get better. Thank you.
Thank you very much, Lubna. That was really fantastic. Gave us an overview of some of your hopes for the European health data space and some of the challenges. We're very tight on time, so I don't think we'll have a chance to take any public questions, but I know you're going to stay with us this morning, and Lubna is in a lovely green dress. It's easy to find her. Please go to her and ask questions, because she's really at the forefront of how do we define AI to serve health outcomes rather than to sell products or something else. So she's got a very clear vision of how we put the human in the center of AI. So thank you very much to Lubna. Now, Lubna spoke a lot about the fact that we can deliver for health outcomes, but also for green outcomes. So let's now explore in this session, we're looking at the green transition. Now, I know that for many people, the full impact, the carbon footprint of the health sector is not so clear. So let me invite two speakers who are going to join me in person. I have a speaker who's joining me online. But let me invite Sonia Roshik, the Executive Director for the Geneva Sustainability Centre, to join me on stage, and Sir Kieran Devane, the Chair of the Irish Health Service Executive, to join me. Now, let's start by understanding, we've just had COP27, where countries were expected to make more and more ambitious commitments. The 1.5 degree of warming target is just about still alive, although we were told it's on life support. So the health sector has a role to play in it. It's going to be heavily affected by climate change, but we also need to understand what's our role in it. And so, Sonia, let me invite you to give us a first perspective to understand, what is it that we need to know? What's our starting point, and where do we start thinking when we use the word greening our health system?
Thank you so much. I'm delighted to be here. And I guess there's two starting points. One is that climate change is a health issue. It's inherently about our health. It's not just about the environment. We can't have healthy people on an unhealthy planet. So the quicker we realize that this is a health issue and therefore should be integrated into everything we do in healthcare, the better. The other one is the size. We know now, thanks to the Lancet, and I know we'll hear from Marina later, that 5.2% of global emissions are from healthcare. It is bigger than shipping and aviation put together. So this is an industry that matters, and we need to do something about it. We often forget to consider the healthcare sector as an industry, and that's all of you in the room here, from industry to politicians to healthcare providers and policymakers. And what I'd like to say about that is that everybody has got a role to play, because there are so many areas where we'll need to transform. It is about transformation. And if you model ourselves to 2050, like we've just been encouraged to do, and often this is not something we are very good at in healthcare, because the future is sometimes tomorrow or this afternoon, we know that these emissions could treble. So this is not something that's going to go away. It's an impending crisis that is already with us and that we need to do something about. And because the way it's been talked about, we need to not only understand the data, but we also need to start thinking about what that means for the way we deliver healthcare. And we've talked a lot this morning about the fact that if we can focus on health rather than sickness, we can start that transformation. And that's absolutely critical. If you can reduce admissions because they're not needed, you can also reduce emissions. So not using stuff and not using products because we don't need them is absolutely key to that. So the personalization agenda we've heard about, the AI agenda can contribute to it, but my plea to you is, can we also integrate the green agenda, because otherwise we'll get it completely wrong. I think I'm going to leave it there because I know that we're tight for time and I could go on forever.
Thank you. I'm just allowing that to sink in, that the emissions from the health sector are more than aviation and shipping combined. Now, we know that we've got people protesting outside airports because of the aviation emissions. Now, I'm not suggesting that we have people protesting outside our health system, because we already have that challenge with vaccines, but this is a huge headline news, and I think it would be a surprise to many people. It was, in our briefing call, it was quite a shock to me. In the back of my mind, I kind of thought, yeah, energy, we use a lot of it, a lot of waste, but I had no idea that it was at that level. And clearly, I know that many health professionals and health sectors declared a climate emergency last year at COP. So, what are the starting actions? We need to be first out of the block at EU and national level. What's your best advice?
So my best advice is to get started now on some no-regret measures. Yes, we've got to measure our footprint and reduce it, but you can spend 2 years trying to perfect that and waste 2 years. So my concept is get started now. There's a lot of things that we know we can do now that are going to be of no regret. You know, you can reduce waste, you can prescribe better, you can focus on health and well-being, you can support health professionals to be empowered to make decisions closer to patients. There is so much you can do. I mean, of course, there's all the energy efficiency, there's all the you know, transport, buildings, food. But as we're a healthcare audience here, I'd like to call you to think about the things that are specific to healthcare. You know, so medicines, medtech, how we deliver models of care that are low carbon and resilient, because we need to develop resilience at the same time, because, you know, we had heat waves this summer in Europe, which are going to be difficult to deal with. So we need to grapple with these issues. And the only way to do it is to integrate them and transform them. And it's going to require all of us in the room to collaborate to find the right innovations. This is an innovation summit. We're going to need plenty of innovation for this.
Thank you, Sonia. Kieran, let me invite you to come in, because in Ireland you've got a brand new strategy and plans for green healthcare. Can you take us through that plan and what enabled you to do it right in the middle of all of these other multi-poly crises that health's trying to do it? How did you find that clear space to do it?
Thank you, and nice to be here. The first thing is the government told us to do it. So all public bodies legally have to produce a plan to eliminate fossil fuel heating by 2024, and you can argue about whether this is ambitious enough, but to have a 51% reduction in carbon footprint by 2030 and be carbon neutral by 2050. So we all have a duty. So you're right that we have a new strategy. In fact, it's so new that we actually launched it on Friday. So. But it was this thing around saying, let's not spend 2 years analysing. We know that there are things we can get on and do. So the way we're seeing the problem is we've divided it into 6 tasks that we have to do. There are 6 things we need to worry about. The first is buildings and the environment around them. So healthcare is huge, as we know. You know, invariably, healthcare is the largest employer in a country, quite often the biggest employer in a town. We have big buildings, they're often old. You know, our head office is an 18th century hospital. They are not designed to be eco-friendly. So the first thing to do is sort of have a program saying, what are we going to do about our infrastructure and our buildings? The second one is transport and mobility. You know, again, we are if you take us, we're the largest employer in the state by a large factor. Lots of people travel into work, lots of people come and obviously visit healthcare settings. How we do that and how we integrate into transport is really important for our carbon footprint. The next one is we're big purchasers. You know, the biggest cost in healthcare, as we know, is workforce, but actually we're still, despite that, we're still huge purchasers in any economy. So therefore we have an obligation to work with our supply chain to work out how do we make the supply chain greener. The next one is water and waste management. We're big consumers of water. Most hospitals have an incinerator. You know, how good is it? How old is it? What should it be doing? What needs to be incinerated? What doesn't? And then the 2 biggest ones, I think, or the 2 which will be the biggest challenges are, first of all, what are those greener models of healthcare? Now, we will never get anywhere if we say, we're not going to give you the best care, but we've got this nice green one we're going to give you. So it's actually around finding what are the models of care which do both. Now, fortunately, the big challenges in healthcare are the aging population. We know that life expectancy goes up 1 year every 4 years. So we have a huge population emerging of older people who are healthier than their cohorts of 5 years ago, 10 years ago, but the population of 85-year-olds will still be huge consumers of healthcare. They do not want to be in hospital. All the evidence is that's bad for the outcomes. So therefore, what are the greener models of healthcare that support people to be at home, which allows us to deliver care through AI, through remote monitoring, through whatever it is, allow us to do that. Now, one advantage we have is we're not just the healthcare system, we're also the social care provider for the country, purchaser at least. So that integration is going to be incredibly important. And then the last one is the adaptation and resilience. So it's the impact that climate change will have on us. What hospitals are going to be flooded, what ones are in places which are vulnerable for whatever reason. So it's those 6 topics we think are the major ones. But if I can pick up again on this point about getting started, we have what we call shallow interventions, replacing the light bulbs with LED lights. So you can do that. And collectively, across the largest employer in the state, that will make a big difference. But what we're calling the deeper interventions around the installation, around the design of HVAC systems, what temperature does a hospital really need to be at, as opposed to the fact that we all set them at a high temperature because we think that's good for people. So those ones will take a lot longer. So you can get started. You do have to be structured. We do have this role as a kind of a beacon public organisation, because if healthcare doesn't get it right, you can be pretty sure the other health public bodies aren't going to get it right as well. And the government told us to.
Thank you very much. I mean, you're definitely a man with a plan. And I found it interesting when Sonia, you talked about no-regret interventions. Kieran, you've talked about shallow interventions. But the clear messages coming through is start. Act now. Don't be paralysed by waiting for that, the final perfect solution. And Kieran, you also highlighted that in healthcare, what people want is the best. And if there is any concern that what they're offered is not the best because we're trying to meet some other green objective, clearly we are going to meet resistance both by the patients and the practitioners. So it's a process where we have to bring people along. I'd like to introduce our final panelist. That's Marina Romanello from the Lancet Climate Countdown, who's joining us online. Hi, Marina.
Hello, thank you so much for having me. And I'm sorry I cannot be there with you in person. I would love to be there, actually. It looks like a very nice room full of people.
It's a great room, and we're a very lively crowd. So what I want to ask you, and we touched on that a little bit, is, health systems are currently in a crisis, but you know what? I've worked in health policy for 20 years, and there's never been a time when there hasn't been a crisis of one type or another. So, how do we build in dealing with the climate crisis along with everything else? We heard from our first 2 speakers that actually they're connected, and delivering green and sustainable care is also part of the health system transformation. But let's build up the evidence on that.
Yeah, so the COVID-19 pandemic has shown us just how frail our health systems are globally. In countries where we have very strong health systems, even then we struggled a fair amount with the COVID-19 pandemic, and we saw the strain on healthcare. And I think that's offered a bit of a glimpse of what it means to have overwhelmed health systems. And what we're seeing with climate change is obviously the health impacts of climate change are increasing really rapidly. We're seeing multidimensional and compounding impacts from climate change, anything from extreme weather events that put acute pressure on our health systems, but also increases in non-communicable diseases that come from climate risks and from our exposure to unhealthy environments associated with fossil fuel burnings and to climate change itself, and an increased incidence of infectious diseases as well, all putting further strain on our health systems. And all of our projections show that will increase. So I think the learnings from the COVID-19 pandemic is just how much we need functional, resilient, robust health systems and how frail they still are. So it's undeniable that we will need to strengthen our health systems. But what is important is to understand that tackling climate change can be conceived through healthcare as mitigation or reduction of climate change. That is essentially primary prevention. We need to avoid this increase in health impacts by reducing our chances of the worst case scenario of increasing climate change and the associated impacts that it will have and the strain on our health systems. And then on the other hand, we have climate adaptation, strengthening our health systems, empowering them to respond and to be able to cope with this increased hazard as secondary prevention. And all of that needs to go closely hand in hand, obviously, with reducing our footprint from the health systems. And it can be compatible And the most efficient way of reducing our carbon footprint is keeping people off hospitals because they don't need as much care. And that can be achieved through primary prevention, through more efficient pathways of care, as we already heard, by enabling people to get care at home where they're comfortable and reducing the demands because we're tackling the problem at root, minimizing our impacts on the environment, the negative exposures that we have to all of these environmental hazards, and strengthening our capacity to respond.
Thank you for that. I want to come back to Kieran, because when I was talking to Sonia yesterday, she said something very clearly, and Marina's reinforced that, which is admissions to hospital drive emissions. So the focus is, actually, we know it's quite poor for health outcomes to people spend time in hospitals, and it is driving up our carbon footprint. So part of the challenge, and Kieran, you said there's a trade-off. People don't want to think they're going to get second-class healthcare, even if it might be good for the planet. And we also know that hospital care is not necessarily the best way to provide care, but people see their local hospital as an intrinsic part of their community. Their local hospital is the physical presence of the welfare state. So if you start telling people that you're going to close down hospitals or reduce hospital presence because they could get care at home or telehealth or something else, that's really quite a challenging conversation. Is there anything you can share with us about the experience that you have of trying to take this conversation to the population?
It's a very, very difficult one. The public does not like the local accident and emergency department to be shut down, even if you tell them you're more likely to survive if you go to the hospital 20 kilometers away. What we've been finding is that the best solution is to build something else, which is even closer to them. So primary care centres. Sometimes they don't have to be physical. We're putting in multidisciplinary teams of physios, occupational therapists, speech and language therapists for every footprint of 50,000 people in the country. So every population will have its own team. And what we're trying to do is to link that with the local GP practices and talk them up, so that the association isn't with the flagship hospital in the big city, it's with their local health system. But that innate resistance to closing what we know are acute services, which are much better delivered. You know, who wants to be operated by the surgeon who only does one operation a year? But the public isn't there in most places, in most countries. So you have to build the alternative, and you have to show the alternative is better first. It doesn't mean you're running two parallel systems. It just says you have to bring the public with you, because mostly we live in democracies.
Thank you. Sonia, do you want to comment on that as well? I saw you nodding at some of the things that Kieran was talking about, which is, shifting the emphasis and that the delivery and a broader range of services more available to you locally, and that is one of the ways to help people make that transition. What can you share?
So it's music to my ears, because I'm an occupational therapist by training. So I naturally have always had to straddle the social and healthcare piece, and it's always been difficult because they sort of sit under two different leaderships. And so I'm delighted they're under the same one in Ireland. But just to reinforce the fact that we can, patients do expect us, and we know this from some work that's been done in the UK, they think that we're already delivering sustainable services. Now, that is scary. It's, taxpayers' money, but they think that we're already doing it because we look after resources well, because we are trustworthy professionals. Now, that's incredibly humbling, because we've got a long way to go. And I think there's something about engaging with patients and with citizens on what the future looks like. We heard earlier that we are consumers, citizens, and patients, all of three at the same time. We all have a role to play on all those three fronts. And it is difficult when you're going for a cataract operation to say, actually, do I really need to have it done here, or have a conversation around it? But I think there are models of care that have demonstrated better quality of care at the end of it, better results, and actually higher patient satisfaction. And just to name one, because I think it contrasts with the A&E example, because at the moment we sort of say to everybody, come to A&E and you'll be seen in 4 hours, you know, and then we've got this log of people who don't actually need to be there, who think they're going to get good care, but they're not going to. And it's channeling them into a hospital admission. And, you know, if you look at Kaiser Permanente, where they are both the payer and the insurer, they know it's worth investing a lot of money up front to keep people well and keep people healthy. And they've declared an emergency a failure of their system. Now, wouldn't that be something different if we could integrate that into our way of delivering care? So we do need to shift the models. We need to be creative about it, because it's not saying let's close A&E. It's about something quite different and something much better. And I think that's what I was asked today, what keeps me positive. It is exactly this transformation, because I've got the passion that we can do it.
Thank you. Let me open the floor for interventions. This is an area that the health community may not deal with in a lot of detail. And we heard from Kieran the 6 areas that they're looking at nationally. It's the buildings and infrastructure, it's the transport and mobility, the supply chain, the water and waste management, how to make healthcare green and effective outcomes, and the adaptation and resilience. So that's a long shopping list of things for people to think about when they're already covering budget shortages, health workforce shortages, waiting lists, etc. But it's absolutely critical and part of the shift in care. So yes, we will get a microphone to Andrzej, and would anyone else like to make an intervention? Yes, please stand up.
Okay. The question to Irish government. So, first, how you measure this? What is your? Because I didn't see the program as published last Friday, so I will have a look. Even yesterday. Okay. So this is the first question: how you measure this? What are the kind of indicators you incorporated in the program? The second, what is the investment? Who is going to pay for this? How much, of course.
Yes. And just before you answer, Kieran, let me take Elina as well. You had a question. Stand up, so that's it.
Well, thank you. It's also a comment. I just wanted to advertise a little bit. We have been talking also about the prevention, and Lubna also identified the possibilities for the AI to pick out the risk groups and have more targeted actions at the earlier stage. In Finland, we actually have one planetary health doctor already that is focusing on these preventative actions, but it's just one at this stage. But I think it's showing also example that we are getting there. We are making transitions and transformations in how we think about healthcare and health. It's not only about treating the disease and prescribing drugs and treatments, but how can we make it proactively about the citizens and their health?
Thank you, Elina. Yes, another lady in green. We've obviously got the same memo today. Please stand up. Great.
Thank you. Thanks a lot. I have also a question for Ireland. Sorry. It's very impressive, your plan, and I hope many countries will follow. But I was wondering on the supply chain side, because I have often heard the difficulty of imposing that because of, in order to comply as a provider, you need to somehow be certified, and that there is a difficulty there in order to be certified as a green. So I was wondering how you are tackling that, because it can be used as let's not go that road, because in any case we cannot have a certainty that the supplier is green. So I would like to know more. Thank you.
Thank you. So Kieran, there you go.
We started with people. We've put in energy efficiency officers around the system. They have teams. We identified the high priority energy users who use 75% of the energy. So we started kind of by building a light infrastructure, maybe 60 million euros worth of activity, so that we had people in place who could do 2 things. One is gather that data, but the second thing is get those early initiatives in place to focus on the low-hanging fruit, in the cliche, around it. So we have, just looking at the numbers, we have 11 energy efficiency officers in the system working with 3 regional teams around the country. So we put in a bureaucracy, really, in the nice sense of bureaucracy to do that, so that we had the ongoing monitoring, and we can tell you that our energy is 13% lower than the baseline 2 years in. The certification of the supply chain, there are some things which are already, in inverted commas, certified. You know, none of us support the greenwashing idea. What we're doing is we're saying, actually structuring the conversations with the suppliers, and rather than saying give us a certificate, it's saying what can you do to reduce our carbon footprint and yours, and then coming up with procurement plans. So I don't think we're really focusing on certification, to be honest. I think we're saying, you know, we're measuring our carbon footprint, are you measuring yours? And oh, by the way, how much of the single-use things do we really need in the supply chain? So some of it is the boring stuff. It's, you know, I don't really mean this literally, but it's the pens, it's the paper, it's the concrete blocks, it's the, you know, it's not the MRI scanner that we're focusing on. It's the rest, because, you know, most of what we procure is boring.
Thank you. Sonia, and then I'll come to you, Marina, to add in. Yeah.
Thank you. So I just wanted to say, because we know that so much of the carbon emissions are in the supply chain, but the mistake we sometimes make is thinking it's a supply chain issue, therefore, only. But actually, we are the ones who use the products and choose to use them, and how we use them matters hugely. So we don't necessarily need to, I mean, we waste an awful lot in the way we use things. And there's a wonderful case study in the UK around the use of gloves, where they managed, by raising awareness with nurses, just to reduce the number of non-surgical gloves that were used, which was good for nurses' hands. It was good for, they saved a lot of money, they saved a lot of carbon emissions, and, you know, actually patients were happier not being treated with gloves. They weren't necessary, it had become a habit. And I think they are, what I would plead to is, yes, we need to think about how we can work best with the supply chain, and it's a really important thing to do, and if we can do it collectively, we can make a bigger difference. But we also need to think about how we can just reduce waste and use our resources more wisely, because there is, and on the money front, there's quite a lot of money to be had in actually just doing that well.
Thank you. Marina, can I bring you in on an issue, because you looked at the global countdown, and of course in Europe we have incredibly developed health systems, whereas in other parts of the world we know they're on the trajectory of hopefully building health systems. So what do we, that tells me that the emissions profile of the health sector globally is likely to rise. Is that inevitable? Is there anything that we can do that could ensure that when other parts of the world build up their health systems, they don't end up massively increasing our emissions? Is there a cleaner, safer path for others?
Yeah, there definitely is. And as you said, there's many parts of the world in which the health systems are still growing, and they need to grow to provide proper care and the care that people need. But it's very interesting, because when we look at Europe, when we look at the higher income countries, the health systems are highly carbon intensive. Whereas if you look perhaps at lower income countries, the health systems have much lower carbon intensity. And even if we compare that with the quality of care provided, there's much more efficient countries. Europe in general performs quite well. Most countries perform really well, but there's still a big scope of countries that provide excellent care with very wide-ranging levels of carbon intensity. So even today, we know that we could provide excellent care, being much more efficient in the way that we use resources. Sonia just mentioned the example of gloves. That's a great example. Our unnecessary overuse of PPE is one area in which kind of countries that have more resources or high income countries tend to overuse and overspend because they can afford it economically, but perhaps not so much environmentally. So there's a lot of learnings from lower income settings on how we can be much more effective in our use of resources. And aside from that, it's also worth mentioning that this transition of healthcare, it cannot be done by one health system alone. We talked a lot about supply chain just now. The global health system, as we heard from Sonia, our research shows that it's responsible for about 5% of all global greenhouse gas emissions, but it's also responsible for about 10% of global GDP. So actually our power, including in our supply chain, over changing the way that everything is delivered, not only pharmaceuticals, but we heard about pens, we heard about kind of stationery. The health system is really big in what it encompasses. So it has an enormous power to change how other industries also behave. And what we're seeing, for example, here in England is the NHS in England has taken the commitment of not buying from any supplier that does not at least match their climate commitments. And as the biggest single supplier of healthcare, it has an enormous power over the international markets of healthcare providers. And what it has seen is the private sector starting to come along and starting to match the commitments of the NHS, and that generates ripple effects. And the huge benefit of that, as we also heard just now, is that by clustering, by generating these demands from health systems around the world, we can generate a shift in the whole industry. And naturally, as we do that, and as we start decarbonizing the way that we provide healthcare, the new health systems or the health systems that are growing will come along that trajectory. So there's a lot that has kind of these cascading effects and is being led by mainly kind of the decarbonizing efforts of perhaps in Europe, many of the health systems here taking the lead on that.
Thank you, Marina. Sonia, let me come to you and ask a question. At the moment, we measure the effectiveness and performance of our health systems by health outcomes. We measure the sort of financial inputs and the health outcomes. And we tend to think that Europe does quite well. That's how we measure value for money. But how would we integrate some kind of metric at looking at our green and our carbon footprints? Do you think that that should be part of the way that we measure performance of health systems?
So I totally do believe it should be integrated, and that we have, you know, a sort of triple bottom line where you might have environmental impacts. I'd just widen it beyond just carbon. There's a number of other environmental impacts we could be measuring. There's the economic ones, and there's some social ones, as well as health outcomes. I think there's something about looking at it across the board. The beauty, as we've sort of discussed today, is that some of these measures are, you know, if you start improving them, they can be a win-win-win across all those measures. And I'm going to just divert that question and come back to it a bit, because I know we're talking about the savings you can make and the changes you can make. The health professionals that I've spoken to, they are quite willing to change because of greenness, as opposed to because it's going to save money. So the gloves example, or anaesthetists, they're doing it not because they think they're going to save their hospital money. They're doing it because they fundamentally believe that this is better for the environment and better for society. So there's, in terms of the behavioural changes, quite a piece about knowing what language we speak. But yes, I do believe we need to have much better ways of integrating the measurement. And I think what it will drive us is to this new economics that we've been talking about last night and today, where actually, and be it driven by data or by something else, where we're not going to be paying per product or per activity, but paying for the outcomes. And we need to get really clever at what that looks like. My only plea is, let's not wait until we've absolutely nailed it on the head to make it happen. Let's start introducing it. You know, like Lubna said, because we've got good data, because that will help to drive some of those changes.
Thank you. And Kieran, I'm going to come to you as the last intervention in this session. You're responsible for the health executive, the health service executive, and yet what we're talking about is, as part of this transformation of health systems, it's almost as if we're dissolving away health system as expensive hospitals and turning it into something that is locally based, it's integrated, it's a series of services and tools that surround people. In this approach to transforming our health system and the Green Deal, you know, do you see your job as essentially making it redundant to run hospitals, to have this big infrastructure? You know, how much of a radical rethink should we be looking at?
I don't think it's about making hospitals redundant, but it's about making sure that only things that must take place in a hospital take place in them. Because a lot of things can take place elsewhere, or if you get it right, don't need to take place at all. The model of health that we have across Europe is effectively a post-war construct. And it was right when the idea was, something happens to you, you go and get it fixed, you break a leg, you go to hospital, you have an infection, you go to the GP. They fix you and you go home. populations now, most of it isn't that. It's, you know, the 85-year-old with multiple conditions who is not going to be fixed, but it is about helping them live life as well as possible in that context. We are not designed for that. So the radical shift for me, if we ignore climate for a moment, is to say, how do we do more upfront prevention? How do we do long-term management of conditions? How do we support people to be well and at home? So what's the home care package as much as what is the admissions policy? So I think we have to fundamentally redesign our health systems, because the system we had has been brilliantly successful. You know, average life expectancy is north of 80 across Europe. That wasn't true in 1950. But we are designed for the wrong thing. So we have to not tear it up, but we have to know we're heading for a completely different destination.
Thank you very much. And I'd like to draw this panel to a close. So thank you to Sonia, to Kieran, and to Marina. And my reflections here are that it's about a direction of travel. And I think all day we've been talking about a direction of travel of where we need to go. And you've added a whole level of both complexity, but also simplification. The things we need to think about and take into account are more complex, but there's the simplicity of we're looking at outcomes and the best outcomes for individuals. And sometimes that will be in health systems, sometimes it's supported in the home and in the community and with tools that help keep them healthy. I think that's a really effective message. And we need to be aware, and I think we'll talk about that in our next session when we talk about the reality of the changing shifts in our population, who they are and how we deliver care and how we support them. So I'd like to say a warm thank you to Sonia, to Kieran, and to Marina. Now we're going to offer you another short coffee break, and I hope you're going to reflect on some of the things that you heard, not least the extent to which the health system is a big part of the climate challenge that we have to deal with. And this time the coffee is on this floor, so you'll be able to, there's a coffee station over here and there's another coffee station over there. So please feel free, get yourself a coffee, something to eat, and we will start again at... No, sorry. We will start again at 12:15. There's coffee this way if you like it. It was really. That's the word. It was.
Recording stopped.
Hello, can you cut my mic, please?
Recording in progress.
Yeah. Thank you, ladies and gentlemen. I know. Thank you. Please take your seats, ladies and gentlemen. Thank you. Now, this session is on aging well in Europe, and I'm looking at the demographics of this room, and I can see that it would be of personal interest to many of us in the immediate or medium-term future. So, we heard earlier about the changes in the way we need to think about health systems. We talked about individual citizen empowerment, and we've talked about citizen engagement and patient engagement tools. But in this session, we're going to look at ourselves in the mirror. In the same way the session just before the break held up a mirror to the health system and said, you are a bigger proportion of the greenhouse gas emissions than aviation and shipping put together. Now take a long, hard look at yourself and think about what you can do. We're now in this session going to hold up a mirror to our society and understand the implications. So I've got a fantastic panel that are going to help us talk this through, and I'm going to start with Jane Barrett from the International Federation of Aging. Now, Europe is aging. Do we really know what that means? Have we understood what the implications are for our society, for our economy, our infrastructure, our way of being and living?
Yes, of course we understand it, because Europe has been ageing for many decades, just like many countries around the world. I think what we don't understand as well is the external drivers alongside population ageing. Population ageing is a demographic upheaval. That's alongside migration, globalisation, urbanisation. And we heard in the last session, climate change. And so these are converging forces that are unprecedented in our time. I think that's one of the challenges. We seem to actually talk about population ageing as an outlier, when in fact it's not. You know, we know that we're all living longer in many countries around the world, but it's the added life years in health that we need to be concerned with. We also know that non-communicable diseases, you know, about 90% of deaths are related to non-communicable diseases. But we also recognise that 80% of disability-adjusted life years are because of non-communicable diseases. The question that we need to be asking ourselves, Tamsin, is where do we invest? Do we invest in compressing morbidity or extending life expectancy? And it's an obvious answer. We need to compress morbidity, because if we actually invested in health promotion, prevention, non-communicable diseases, then in fact that would give us a social and economic benefit far beyond increasing life expectancy. And it interrelates with long-term care and interrelates with our healthcare systems. So, yes, we do know a lot about it, but it's about bringing together a joined-up approach around population ageing.
Thank you, Jane. As Europe moves towards 2030, when we're going to be the oldest continent in the world, is there anything we can learn from anywhere else in the world? Is there anywhere, a country or region that you think has really got to grips with this and understood how to change their systems?
no one has got to grips with it because it's evolving, it's a dynamic process. But we know that Singapore, for example, have invested tremendously in lifelong learning. That's a good thing. They also have invested in small grants, over 25, for as many years to learn more. They've also invested in social risk pooling. So in terms of trying to understand how much money you've got to live on post-retirement, there's a government fund. Japan, long-term care system, insurance, and it is now beginning to reap benefits. What's the return on investment? And of course, robotics. We talked a lot about carers across the course of the day, and we now have real evidence that robotics are going to actually pick up a lot of the LDA, ADL kind of care, the personal hygiene. And so we can invest in the human touch in the care and support of carers.
Thank you very much to Jane, and also giving us a sense of the future and where we go for this. And there are other places where we can look to explore, to learn more. Let me now pass the floor to Joost Korte from the European Commission DG Employment. We've got a brand new care strategy for the first time at EU level, which is really quite a milestone. Why is this the right moment? Why has it taken us this long to get to having a clear message at EU level?
Thank you very much, Tamsin. Yes, well, it's true actually that in the Commission we've been looking into the care sector since many, many years, but it always stayed at the level of analysis. So we actually know a lot. We accumulated data, how much a member state spent on care, how many people are working in the care sector. We've given also some recommendations. There are ESF, European Social Fund projects. But it's true that only in September we came with a package which is really composed of policy proposals. First time we move into the policy area. So why is this? I think it's a communication and 2 recommendations to the Council, both of which will be adopted on the 8th of December, so it goes quite fast. Proposals were made in early September. I mean, Ursula von der Leyen announced this a year ago in September 21. And then within a year, the package was on the table. I think a couple of reasons are not only the speech, but obviously COVID. COVID, I think, showed to everybody how important the care sector is, how fragile the care sector is, and that actually is true for the whole, also for health. I think it was an eye-opener. Not new in a way, because those people who read the analysis knew where the weaknesses are, but of course we saw it very, very clearly. That was definitely an eye-opener. I think also member states' preparedness to think about EU-wide solutions grew a lot, in that they saw that these are not issues that can be solved easily in a member state only, in an area which is obviously much more reserved for member states' competence. I mean, if you look at the treaty, it's not so easy for the Commission to come forward with policy proposals, but I think the political willingness, preparedness on the side of the member states has grown a lot because of COVID. Then there's also of course, the pillar of social rights, with an action plan to which the Commission committed itself, and Ursula von der Leyen in particular. So there are 3 principles there that concern the topics of today's discussion, and they had to be implemented. So that obviously we're doing. And then I think finally, I mean, aging. Of course, we're not blind. Aging is having a huge impact on the societies, and that filters through to the EU level. Even though aging, I don't think you find it in the treaty as an issue that the EU should deal with. But as we see, the world around us is changing, our own societies are changing, and the European Union is a beast that then adapts. So we get into areas where we have so far been a lot more reserved.
Thank you, Joost. And just to give us a very brief highlight, what do you hope will change with this strategy? How would we see and experience something that's different?
Well, as I said, there are 2, it's a strategy, but it is also 2 legal acts. That's quite important. There are 2 recommendations. Okay, they're not legally binding acts because we can't. The treaty does not allow the Commission to put forward binding legislation in this area, a directive or a regulation. I mean, when everything gets very hot, it becomes always fluid. So who knows? Huh? I had never thought that we would be going into energy, for instance, with a legally binding proposal. So maybe this may happen over time as well, if the lawyers become a bit more flexible. But for the moment, it's a recommendation. That means that ministers commit to it, and they will do this on the 8th of December, and they don't do this lightly. So I think there is a true commitment through these legal acts. Now, there are two elements, I think, which I would like to mention. I think there is the obvious point of access to the care sector, the quality of the care sector, and the affordability, where the recommendation contains a lot of criteria and suggestions for member states how to improve all three. And secondly, and that's maybe also quite a new dimension, it's the people working in the sector, the carers. So a lot of the recommendation focuses on them to improve their working conditions, to make it more attractive to work in the sector, to do more about their skills, including the recognition of skills, because you can be a very good carer in one country, it's almost impossible to move to another one because the diplomas don't match, and it's not a regulated profession at EU level. And then there's also a dimension there which is a bit subsidiary but nevertheless important. It also has a dimension of legal migration from third countries. Because if you look at the shortages that are there already today, and I'm sure Stacey will talk a lot about it, but in our paper it says 80%, today 80% of the care, long-term care, is done by families. So, which also has a lot of impact on the way our societies are organized. It's a huge gender issue because we know very well who in the family is concerned about. And so, and that then brings you into also the sort of positive side of these investments, because you could easily imagine that with the right investments, the right policy mix, this can actually trigger growth in our economies. It's not only cost. If you do it well, this is a huge potential also for growth of the economies and for more fiscal income for the member states. So those are, I think, the essential points where we hope changes will be made. We will obviously follow up. The recommendation, if you read it, it's full of follow-up points, reporting. Commission will be very tough to scrutinize what member states are actually doing.
Thank you very much. And let me now bring in Stesi Ingemos from the Eurocarers. You know, you're the executive director there, and I know that for years you've been raising the issue of the role of carers, whether formal or informal. And here we are, we've got a strategy on the table. So here, let me help understand what is the relevance of dealing with this at EU level. Why did it need to be addressed at that fundamental top level?
Thank you, Tamsin, and good morning, everyone. Yes, we've been pushing for an EU initiative on the topic for probably more than 15 years. Well, first of all, why do we need an EU strategy? As we just heard, you know, all of the member states face extremely similar challenges in terms of the growing prevalence of chronic diseases, the growing demand for care, the declining supply of both formal and informal carers, because of difficult working conditions, inadequate training, and as a result, obviously, a huge quality and sustainability challenge for our care systems. Also, all member states tend to rely very heavily on informal carers or family carers or unpaid carers, as they are known in different places, but essentially family members, friends, and neighbors who provide usually unpaid long-term care. And obviously, indeed, it is a strong gender dimension. So from our perspective, it's a major achievement that we now have an EU care strategy. I mean, 8 years ago, when I joined Eurocarers, member states didn't want to speak long-term care together at EU level. And now, 8 years later, we have common goals. So at EU level, quite frankly, I've been active at EU level for probably 20 years now. 8 years is a fairly short amount of time. So that's the first reason. The second reason, of course, is that population exchange trends tend to coexist with, many older people choosing to move, from northern countries to southern countries, for example, with their carers to, maybe have a better quality of life, better weather, and also younger people who will decide to move abroad to study or work. So people move around, across the EU, and that raises questions when it comes to long-term care about the portability of these rights and the eligibility of accessing support measures across the border. So for all of these reasons, it does make sense to have at least a coordination mechanism at European level in the field of long-term care. Yeah.
Thank you, Stacey. And the long-awaited care strategy is here, and given that the pandemic put in very sharp relief the risks and weaknesses of our long-term care system, where for many older people, actually being in an institutionalized care home was a higher risk factor of getting and dying from COVID. So we saw the gaps in the system. What are the risks associated with this new care package? Where are the gaps that are still not being filled?
Yeah, well, first of all, again, it's not every day we say this, but the Commission did manage to tick many of the boxes we were expecting, so kudos to the Commission for that. In terms of the challenges, well, the strategy is only a strategy, it's only a plan. So now that, member states are about to approve the strategy, endorse it, we need to see how it is implemented, how it is interpreted across the Union. As I said, what we expect is a redistribution of responsibilities between individuals and the collective. We need to address the over-reliance on informal carers because, informal carers tend to face a long list of challenges on their own as a result of their caregiving in terms of their ability to access education, employment, in terms of poverty, social exclusion, and also negative health outcomes. So we need to address that. And one of the risks is now that we have the strategy, and the strategy does recognize the need to support informal carers, we want to avoid a situation whereby member states would shift away responsibilities from professional care to informal carers while, throwing a few, rights here and there. And then, problem solved. Obviously, that's not what we want to see. Yet, it's going to be impossible or extremely difficult to replace informal care by professional care altogether, because the value of informal care far exceeds current budgets devoted to professional long-term care. So we'll need to maintain some, some portion of informal care in the care mix. And so another risk or another challenge will be to decide what is an adequate mix between professional and informal care. And how do we also maintain choice for informal carers about to what extent we all want to be involved in the provision of long-term care and whether actually we want to be involved in the provision of long-term care. The third risk, obviously, is the elephant in the room, is the sustainability. How are we going to pay for all of that? I'm not an economist myself, so I'll leave it to the economists in the room. And the fourth challenge we still see, or the limitation of the strategy, if I may, is the fact that EU institutions and many policymakers continue to approach informal carer exclusively as a barrier to other productive activities, so money-making activities, essentially. So in other words, the value of informal care, or the value of trying to address informal care only lies in ensuring that people can be productive. But actually, obviously, the provision of care is much more than that. I mean, that's part of the human experience. And we also need to recognize that it contributes to social cohesion and intergenerational solidarity. And we need also that in our society. Yeah, I'll stop there.
Thank you very much, Stacey. Let me now invite our speaker who's joining us online from Copenhagen, and that's Natasha Azzopardi-Muscat, the Director of Health Policies and Systems at the World Health Organization. Natasha, welcome, and thank you for joining us remotely. We've been talking here about how, we heard from Jane, is the goal is to improve healthy life years and to compress the morbidity towards the end of life. And we also heard that Europe is not really got to grips with the implications of aging, although in the earlier session we heard that actually we've been increasing life expectancy every 4 years. So this is something we should have planned for. Can you tell us, have our health systems ready and set up to deal with an aging population? Have we been sufficient in our planning?
Thank you, Tamsin, and it's a pleasure to be able to join you briefly in between events, and indeed it's a fascinating conversation. So let's just start by celebrating the fact that life expectancy has been increasing and not taking this for granted. In fact, what we are seeing in the aftermath of the COVID pandemic is that in a number of countries, life expectancy is sadly stagnating. So I think we should take a moment to recognize the success and achievement that the European region has had. Of course, we are not only concerned about adding years to life, we want to make sure that we also add life to years. Aging is inevitable, but healthy aging requires us also to invest very much in prevention and in ensuring that people can have access to all those factors which we know will enable them to age more healthily. The second point is really around, I think, debunking some of the myths. We know, for example, that it's typically the last year of life that is the most expensive. And of course, it's a good thing that most people have their last year of life increasingly at an older age, but not everybody has the privilege of achieving their last year of life at an older age too. In terms of our health systems, let's be frank, health systems across the European region are struggling. They are struggling badly. They are struggling because they are still seeking to recover from the years that we have gone through because of the COVID pandemic. They are struggling to catch up with backlogs, but there are also other emergencies in Europe, not least the war in Ukraine, for example, that are putting pressure on health systems. But not all health systems have coped in the same way. What do we see? We see that those health systems that were able to invest, for example, more in strengthening primary healthcare were able to cope far better, whilst health systems that are still very, very dependent on siloed hospital specialized care approaches were not able to cope so well during the pandemic. And this in turn is, of course, part of the preparation for an aging society, a society that is going to spend part of its life with chronic comorbidities that are far best tackled through a multidisciplinary team outside the hospital setting. We want to keep older persons away from hospitals until they really have to be there because it's the only place for them to be. And in that case, we need them to be there for as short a period as possible. And then we come to the issue of care and long-term care, which previous speakers have spoken very articulately about. And we are seeing that more and more member states are now seeking to invest in rehabilitation, palliative care, and long-term care. And let me just say that within our service delivery program at WHO Regional Office for Europe in Copenhagen, it is no coincidence that rehabilitation services, we will be launching a landmark report next week. Long-term care and palliative care are the three areas that our countries have asked us to really step up our work on, because all countries, irrespective of their level of development, are facing challenges and are seeking to develop joint solutions. The challenges lie also inherently in the lack of a care workforce. Because Europe is aging, the health workforce and care workforce is aging too. Part of the solution has been to try and import a care workforce, but that in itself is not sustainable, in addition to the ethical dilemmas that it is creating. And this is why we need to really think out of the box and think innovation. But let me not forget, for example, mental health. Last week we had a meeting of our mental health coalition, and one of the work packages that we are taking forward is the mental health of older persons. And with this, for example, we have dementia on the agenda too. Again, a huge area of concern that requires care and support, and where we feel that our health systems are struggling to keep up and are chasing behind the curve rather than being ahead of the curve. So I think the message is, yes, we need to really think, what are the health systems that we need in a digital era with an aging population, with a finite health and care workforce, but with the opportunities also that technologies offer to us. But this means that, for example, we need to very much invest in the digital health literacy of older persons too, to enable them to benefit from the opportunities that there are available. So those, I think, would be a few thoughts that I would like to leave with you. Unfortunately, I will have to jump off at 1 p.m. But thank you very much once again for inviting me to be here and share the perspective on behalf of the WHO's Regional Office for Europe.
Excellent, thank you very much. This is a very useful intervention. We're going to now open the floor for a short Q&A before we go on and invite our next speakers to join. Is there anyone who would like to ask a question based around what we've just heard? We've set out very clearly the changes and the challenges that gives to our health systems, our society, about an ageing Europe, an ageing population, an ageing workforce, and the burdens that has put on carers. We've heard that the 80% of care is delivered within families, and that largely falls on women. There are gender aspects around that, not least because the women who take on that care then experience higher risk of poverty, they don't get a pension because they haven't contributed, and that work is just not valued. So lots of different issues and challenges put on the table by our speakers. Would anyone like to ask a question at this point or raise a contribution? Yes, if you'd like to stand up, please, and introduce yourself. Thank you.
Okay, thank you. Bear Omer, European Specialist Nurses, Executive Director. A very interesting and very relevant topic at the moment, the aging and the elderly. And we often speak about the role of the healthcare professionals. But what we do experience that often nurses are not facilitated in the education competence. Take, for example, in the palliative care. There are groups specialized in palliative care. They have their own education structure, they have their own curricula. But if you go to the hospital, then they say, well, you got your 8-hour shift, you have to work for 8 hours, and the rest is your responsibility. So I know it's a nurse's responsibility to be competent. It's a very personal one, but they have to be facilitated. Also, if you just take them in the 4 hours, five days a week, they wouldn't be allowed. So I think in this whole domain, in the care strategy, we also need to include budgets and really invest time for them to be competent. Otherwise, it's a brain drain, and then it's becoming by the endangered species, and we need to avoid this.
Thank you, Bear. I think that's a very useful point, which is we need to look at our health workforce as a precious resource, and not just people who need to deliver the work in the sector, but also invest in upskilling them and giving them the opportunity to take on the special skills that they need to go forward. And Jane, yes, please respond on that.
I felt it's very important to respond to your comment. You know, for 2 years, many countries around the world were banging saucepans in celebration for the work of the frontline workers, right? Every Friday it was, you know, where I was living. And yet the saucepans have stopped banging. And yet the burnout of nurses and other frontline professionals continues. So when we think about healthcare system reform, then part of my thinking is that we really need to invest in the continuing education. And I understand what you're saying, that it is our responsibility as health professionals. And yes, we need frontline professionals to be expert in what they do. And if they're not, then we're the first to complain, the general public. And so I would certainly support and be a strong ally, you know, in calling on governments, member states, to invest in the continuing education of healthcare professionals. Otherwise, we don't have health system reform. So thank you for your question.
Thank you. Joost, can I ask you to pick up on that? And Stacey, this measure that we need to look at our health and care workforce, not just for the app, because they get paid for the hours that they do, but we're not investing enough in giving them the time and the space and the paid time off to go in and upskill and move to that next level. And, you know, as Jane has said, we've stopped banging on saucepans, but this is a way that we offer a career path and a recognition. Is that something that's foreseen, or is that another one of those things that is left to either national level or individual employers?
Yeah, no, but I agree very much with what Jane said, and also with the question. I think this is, I think, fairly consensual that more investments are needed in the workforce, and also the work needs to become more attractive, which means better pay and better working conditions, including upskilling, reskilling, not once, but forever. It never stops. And that, by the way, is not only true for the nurses. It also applies to many other professions in the European Union. So more investments indeed, and make it more attractive for people to work in that sector, because I mean the perception is not very positive, honestly. So that's very. But I think member states realize this, and they are prepared to work on this. And again, the recommendation contains a lot of good ideas and suggestions how to do this in practice, so that it doesn't stay, you know, at the level of nice interventions in conferences, but that something is actually happening on the ground. If you look at the total amount that member states spend on care, on long-term care, it's 1.7% on average of the GDP. But that's the average of the EU. That is for very rich countries to very poor countries. It's not so relevant, I think, as a figure. It gets a bit more relevant if you compare it to other averages, like pensions. On pensions, the EU 27 spend on average 11.6%. So 1.7 on care, and 11.6 on pension, and 6.6 on healthcare. So there you see that care is really low. And if you go a bit deeper into that 1.7%, in fact, most member states spend less than 1%. And why? Because they rely on Stacey's people. Huh? This is the way out, of course. So I think whatever way you look at it, and I'm not in any way proposing, you know, that member states should acquire more debts forevermore, because the demand is maybe also infinite, but definitely more needs to be spent in those countries that are so low at the moment, in order to make that the working in the sector more attractive, and we need these people.
Thank you.
Could I just make a point?
Yeah.
You know, the investment is also proportional to the disability adjusted life years, you know, to the functional ability of the population, and we just don't have good data on this. So we're investing in 1.7, or whether it's 0.6, or we actually need to start joining up the dots to understand what is the percentage of informal carers in the workforce, what's the percentage of frontline workers, you know, what's the percentage of people that have a fall and have a premature admission to hospital. So it's really a joined up approach that we need. Sorry, Stacey.
No, that's okay. I agree with you that we certainly need more data. I would at the same time say that we have enough data to act, yes. You know. Maybe I completely agree with what's been said. Maybe to add to that and to illustrate that, out of the roughly 6.3 million people who are part of the long-term care workforce in the EU today, 70% are personal care workers with no nursing degree or very limited training. So when we speak about quality, obviously we need to invest in training. I mean, there's no way around it. So just to agree with all of you.
Thank you. I'm now going to bring in our next two speakers to add a little bit more to this. So I have with me Sean Lybrand from Amgem, and we talked, Jane gave us right at the beginning these big statistics. It's the NCD burden. It's a bit like it's the economy, Stu, but it's the NCD burden. If we can keep people healthier longer, that's surely going to work. So if we could identify and manage the non-communicable diseases earlier and better, how would that support the goals of the long-term care strategy?
Sure, thank you. I do think one of the goals of the long-term health strategy should be to avoid having people in long-term care for as long as possible. And Jane picked up on that with respect to the compression of morbidity. A previous speaker, so Kieran, I love the fact that social care and healthcare lines up, because then you have a line of sight over the budget, and you can take the Kaiser Permanente-like approach that was mentioned, which is if you can manage people going into the system, you can also manage costs. So from my point of view, the idea that we have a comprehensive long-term care strategy in Europe is excellent. It needs to be supported by a long-term primary and secondary prevention healthcare strategy as well, which of course, at least in cancer, Europe has done with the Beating Cancer Plan that they announced a short while ago. And as you know, a beating cardiovascular disease plan is hopefully going to be tabled at some stage. So by joining up particularly preventable conditions through identification and management of non-communicable conditions, there is a cost to that, but it's cost effective. We must remember that healthcare interventions are some of the only things that are assessed for cost effectiveness across the whole of the government system.
Thank you. And where do you see the role of innovative therapies and their modalities of delivery fitting into that broader picture of supporting individuals to better manage their care?
Sure. This might seem, from an industry perspective, to be different, but the importance of the non-communicable disease approaches is that there are many, many medicines that have proven to be cost-effective in managing at the secondary prevention level cardiovascular disease, diabetes, chronic kidney disease. So I think it's the importance of trying to blend in secondary prevention approaches, of course, which primary care gives, but also trying to help engage people in their own health. One of the issues with chronic disease as opposed to rare disease is that chronic disease will sneak up on all of us. Most of the chronic diseases that we can have are things that don't have symptoms until later stages. The first thing somebody knows about a heart attack often is a sore arm or that, and the first heart attack can often be fatal. So the idea of managing care and ensuring that cost-effective medicines and other modalities are used early in care will hopefully leave long-term care to the people who really need it for as long as possible.
Thank you. Andrea, let me bring you in from Edwards Life Sciences, because again, we're talking about how do we deliver on this vision, or we spend an insignificant amount of our money on prevention and promotion, and we need to sort of shift our focus and our spending on this. So as a medical technology innovator, where do you see that the piece of the puzzle that innovation could deliver, and what do we need to change now so that we're more prepared for the inevitable aging of our population?
Yeah, let me say a couple of comments very briefly. I think that we all understood that European population is aging. So we keep studying, rediscussing. By the end of the day, this is a region of the world that is dramatically entering in an aging phase. It's not anymore an issue of a demographer. I think the European Commission, if I well remember, in the early 2010, launched an active and healthy aging innovation partnership. That was the first time that was really putting in front of member states, policymakers, decision makers, different societal the issue. After 10 years, we know that, we got it. So this is great. What is the major issue? That we try to address that with healthcare system that they were designing 50 years ago. The COVID story, the pandemic, has simply accelerated slippery slope. Cioè has put maybe in a couple of years what would have happened in the next 5, 6 years. But fact is that today even we start to say, well, we need to pay maybe €100 more nurses, fantastic. Doctors, 150 because they are doctors, maybe, fantastic. But it's not just having more doctors, better paid. With that organizational healthcare system, it doesn't work. We will never address that. That's the real challenge that we do have. We like to invest in primary prevention, keep fit, eat well, Tai Chi. By the end of the day, we don't want to get one vaccine in secondary prevention to elderly people. We want to put in a real interventional prevention. That's not the issue. When they enter in an hospital, they found what already OECD informed us in 2017 about the wasting in the hospital system. Elderly people, they enter, 20% of intervention are poor wasting of money. Processes are old. That's the real. Technology that I use are old. Repetitive. How we found it? We found them. I'm not an economist either, but we fund them if we cut that wasting and invest in innovative technologies. Technologies that are able to, A, improve health outcomes, which means individually and collectively, make elderly people or senior society more independent, better contributor to society, taking them out from the hospital faster, but better, and third, which is even more important, increase the level of the population health. So collectively is a benefit. That innovation in processes as well in technologies can have a real impact. And I think that most recently with the Innovative Health Initiative, the European Commission that has launched now is 18 months, 2 years ago, that's the way, test and trial innovation in order to adopt. Generate evidences, but test and trial, not remain an academic problem. The good news that technologies are there to make that. Minimally invasive transcatheter, digital solution we heard early this morning. But test and trial, make use of them. Clinical decision support system, the real element of the digitalization. Digital is not only how we can build a mega database, but clinical decision support system in the different phase of the patient journey. These are critical. Test and trial, let's make use of them. Adopt, invest in them. And then we were able to have maybe in a couple of years the same session where we start to measure the outcome of all that.
Thank you. Let me see if we want to have a question from the floor or a contribution on this conversation about healthy aging and our overall approach. We've heard there about using technology better to test out and try things to address failures in our system and our systems which were built for the health problems and the life expectancy of 50 years ago. So it's a big rethink that we need to do. Is there anyone who would like to contribute from the floor? Yes, we will give you a microphone. If you could please stand up and introduce yourself. Thank you.
Thank you. Hi, I'm Nancy from the UK mission to the EU. I really appreciate the panel and everything you've discussed. It's been really interesting. And what I'm really interested in is the preventative care. But I think part of it is a mindset change for the public, as well as obviously the healthcare workers, doctors, nurses, etc. So I was wondering if the panel had any reflections on how we bring the public along with this narrative about investing in their own healthcare and some of those preventative measures. Thank you.
Thank you. I think that's an interesting challenge that Jane, I might put on your desk to answer. And let me also see if we have any other inputs for our panel to think about. Yes, we have a microphone that we'll bring to you here in the front. Just wait, the microphone's coming to you.
Merci. Merci à tous. I try my best English.
Okay.
Well, all this is depending on how we can maintain those people at home. And that is all about investment, of course. And then data has also a duty to offer some incentives. Of course, it's a market, but how people will be able to sustain such an investment on personal ground. This is a big elephant in the room. Thank you to help to answer.
Thank you. So you've raised a very interesting point, which is where the burden is, whether it's on the individual or in society. And in health, we've very clearly said that health systems are there to manage the risk for everyone. But on long-term care, the burden is falling, as Stacey says, 80% on families, largely women, informal care. And if we're going to keep people independent in their homes with dignity longer, then again, that's investment, either in skills or training or adaptations of buildings and homes. And you're asking the important question, where does that investment lie? Who's going to pay for it? And that comes to the point that I think I'd like our panel to reflect on, is at what point are we going to recognise at European level that a functioning long-term care system is a public good and not an individual responsibility to sort out, and then address it with the same level of focus, investment and support as we do our health systems. So Jane, let me start with bringing to you this issue about how do we get the public as involved and invested in taking care of their health over the long term as we want the systems to do.
And thank you very much, Nancy. I think it's a really complex but great question. And the utopian response would be that this is an intergenerational theme, right? And I say that because we know that physical exercise, mental activity, etc., starts really at a school-based age. So, that's what I would say in response long term. But it really requires investment up there. I think the most important message is that we've got the wrong narrative going out there, about investments in ourselves. Because at 20, did I really think that I was going to die of heart disease? No. And so we have the wrong narrative because we don't invest, once again this word, we don't invest in the public health messages that are going to impact you at your age. And we can just look in terms of our whole saga in vaccination as a good example. Older people, what they're told is, it's flu season, go and get your flu vaccine. That is meaningless. We know it's meaningless. So we've got to actually understand what is the effective messaging for that target group and how do they receive that message? Do they receive it on TikTok or Instagram, or do they see it on a poster board? So 2 responses, intergenerational, absolutely. But shape the narrative for the targeted population, and then you're going to get a return on investment.
Thank you. Who on the panel wants to pick up on that bigger picture of, okay, Sean wants to come in, I'll bring in Andrzej, and then I'll come to that side.
At a panel that Tamsin hosted a while ago, the rapporteur said nobody wants to have a little bit of cancer. And the issue with that is that people treat cancer very seriously, despite the gradient of what cancer is. The importance to me on primary care, Lubna raised something earlier today about AI, is that we can use AI and data to be able to not say a person who will be likely to have something, but the type of people who are more likely to be impacted by that. So for me, building in the idea of using data for good, health data for good, to actually point to people not only of the fact that they may be likely for a particular issue, but also the potential consequences. People are more likely to act against a negative stimulus than a positive stimulus in that regard. So how do we, as Jane was saying, early enough be able to develop lifelong healthy behaviours? And it's complicated. I think it's complicated by our lifestyle. But the fact is that NCDs are what drive costs and outcomes in Europe and most other high-income countries in the world. So that is an important area to be investing in as well.
Thank you.
Yeah.
Andrea?
No, I was thinking the gentle lady put a really excellent question, because you were touching really the core is the crossroad between healthcare budget and social care budget. That today are, you can say, siloed, separated, but the patient live a continuum. It's not, they don't get like, you know, now I'm pushing on the healthcare, now I'm pushing on the social care. The people live. They just simply live. So they cross different phases when they have to deal with the disease. And what I was talking before, what we call capacity enhancing innovation, innovation in processes and in technologies that is able to capture this continuum, are not isolated for one disease. When you talk about cardiovascular diseases, the dramatic things today, that was my call before, is not that, you know, we don't treat enough and well patients, but in some heart valve disease, we have people in Germany, France, in UK, that are dying in the waiting list. They are diagnosed, they know, and they don't even forget which type of treatment. I'm not even saying, they simply die because there you say that's a process that doesn't work, as innovation in processes. It's not anymore innovation in technology, because they don't get even the opportunity to get the technology. Which is the right balance between improving the processes, early screening, early detection, monitoring, so risk stratification, understand which type of population will enter in a more risky phase afterwards, and then the technology that can free the people faster from the hospital, better outcomes, regaining normal life, not with 1 year rehabilitation, but maybe with a couple of weeks of rehabilitation, things like that, and re-entering in a positive cycle, being independent, as you were calling. These type of things demand a reflection, and what I was saying, test and trial immediately, because opportunities are there, technologies are there.
Thank you. Stacey, let me bring you in here to pick up on this broader issue of, you know, how we manage that relationship on what falls on the individual and therefore on their family to provide that care when they need it as they get older. And yet in other areas, in pensions and health, we recognize the value of having a collective approach. How do you see that battle? I mean, you talked about it's taken 8 years to get a strategy for care at European level, but the next level is recognizing that we need a collective response to what's currently sitting on individual shoulders. How hopeful are you?
Yeah, that's a difficult question. Look, again, the way we see it, now we have an open door. People are willing to at least discuss the issue, which is already a big thing, you know. But we see more and more member states indeed paying attention to informal carers as a way of now officially financing, in a way, care systems, we've been relying on families for decades as a form of cheap or free workforce. And now we may run again the risk of creating a few rights for these people, at limited cost compared to the investment it would take to replace them, and then continue to rely on them. And so in terms of that balance, what we really want to ensure is that we also invest in the portfolio of alternative options, because one of the key drivers of the high prevalence and the high reliance on informal carers in Europe is the lack of alternative options. Community-based care, home-based care, as we heard. I was very pleased to hear about the Irish plan and the objective of investing at local level. That's what we want to see across Europe. The key challenge from our perspective is what we heard about the need to review old-fashioned processes and probably make some benefits there, the need to invest in a new ecosystem of in the care delivery, and at the same time the need to recognize and support informal carers plus prevention. All of this needs to happen at the same time, and that's the real challenge. So we have a few ideas about how things could be financed, but probably I would speak for an additional half an hour, so I'll stop here.
Thank you. Jus, let me bring you in on, I think, something that Stacey has touched on, which is that the burden of care and the fact that we have for decades relied on unpaid carers to deliver it. Now, the care strategy you mentioned, it creates some rights, it talks about paying conditions for workers in that area, but long-term care strategy is usually delivered or organised at local government level, and they procure usually on the assumption that people who work in the care strategy are on minimum wage. That's the only way that it is affordable for the local service provision. What you're talking about is investing in that, training, offering better quality work. If I was a policymaker, in the back of my mind, I would see, glaring red sign, more money is needed. And if half of Stacey's workforce actually said, well, you could pay us for what we do, that's even more money. As we're looking at a cost of living crisis, you've said that member states are coming to the table. Are they not afraid of the fact that the inevitable result of this conversation is more money is needed, more investment is needed? Or have they recognized that, just like with pandemic prevention, if you cut corners now, you pay for it later? Are they ready for that conversation?
Yeah, no, that's a very good question, and I think there's not one answer to this. I think, honestly, Tamsin, I think one thing which is really true is that it needs to be, of course, as previous speakers have said, an integrated approach. And we were struggling with it ourselves in the Commission, because when Ursula von der Leyen said, I want a care strategy, and I said, yes, but what about health? And how do you, where do you draw the border between health and care? And you see that the strategy is actually early childhood education and care, the so-called Barcelona targets in our jargon, and then we take an enormous leap, and then we go to the long-term care. The whole middle part is, because in our world this is a different DG, and it's also different ministries and different different actors. So this is obviously a handicap. I agree. It needs to be integrated, because if we continue with the health system as it is today, it will just deliver more people into the care, without any doubt. So we need to do that as well. On top of it, however, I remain convinced that more investments are needed. I mean, again, I'm just quoting here the work of my colleagues. They've done some extrapolating work, and they have come to the conclusion in the communication that something like 13.6 million jobs extra will be needed by 2030 if we really want to have a well-functioning long-term care sector. Where are these people? I don't see them. We already have shortages in other sectors, so that's why there the answer needs to be surely more money. They need to be paid better skilled, better education, more possibilities to move around between member states and regions of member states, and then also surely we will need migration. Otherwise, we will never fill this gap, whatever we do. Is there? And then, of course, the question is how much money. These are, at the end of the day, choices that are made. I agree with you that the minimum wage is sort of, the understanding for many, many decades, this is okay for the nursing, for the nurses. But why? Why? I personally don't agree with that at all. I think they need to be paid a lot more. But the same is true maybe for the policemen and the teachers. I don't know. All these sectors of our society that we know now, in particular, and COVID as a wake-up. It hasn't actually changed all that much, but we were confronted with the reality of these sectors that are so important for our societies. In my own member state, for instance, I know this, they spend, according to their official figures in the Netherlands, 4.4% on care. So obviously, the minister, when she came to speak to Nicola Schmid, said, "Oh, I can't spend any more. I'm already, and if I do nothing, I think they did some. It will go to 20%. So this is obviously not an option. I mean, I don't think you can really make so. But then there are also ones who are below 1%, and they should move. And then in the Netherlands, they need to possibly do a bit more on the health sector in order to avoid an everlasting increase of the cost. And finally, as you said yourself, I mean, it's the choices we make at the political level as societies where we want to invest. And these choices are not easy, and I'm happy I don't have to make them. But the direction of travel is, I think, pretty convincingly put forward in the strategy.
Thank you. I mean, I think that's you just described with that anecdote from the Netherlands. What is, I think, the fear is when ministers or policymakers sit and actually look at the numbers and then do some kind of extrapolation to say, well, this is what it would cost. Then I think their automatic reflex is, how do we cut it? How do we cut the entitlement to support now? Because if we might be able to afford it now, but in 5, 10, 15 years, we absolutely could not pay the 20%, etc. So we must stop the rot now. But the way they approach it is that means we cut entitlement rather than some of the things that we've talked about on this panel, which is using smart tools and innovation to help people manage, much better prevention and moving upstream, because that's slow, it's difficult to manage, it involves many other parts. So I think the automatic reflex has tended to be, up until now, how do we cut things? So I'm going to invite Jane to close our panel and wrap up. You opened it by challenging us to say we are looking with eyes from the past and we haven't got to grips with the way things change. And we've had 30 years. This has been a slow pandemic coming at us. What would be the advice you'd like to leave us to address some of these difficult issues in a way that's inclusive rather than automatically closing down the options because of fear of cost?
Thank you, Tamsin. Today we are in the second year of the United Nations Decade of Healthy Ageing. There are 4 action areas: primary integrated care, age-friendly cities and communities, and I want to acknowledge Ireland, because Ireland is the only country that has been submitted a plan to the WHO for an age-friendly Ireland. So there's some indication there. The third is combating ageism, and the 4th is long-term care. Each of these action areas connect with one another, and that's the very essence of what we've been talking about today. What's most important is the enablers. The enablers are voice and engagement, which is what we've been doing here. Leadership and capacity, which is what you do. Monitoring and surveillance, and that's where we need the experts in academia. And finally, the coordination and multi-stakeholder engagement. Friends of Europe is a very important and interesting summit because it brings together cross-sector and cross-disciplinary approach. So I am optimistic of the future. I'm not pessimistic, because we have the best minds and thought leaders, who I'm sitting between, that understand the issues and are investing in joined up government and joined up portfolios. What we perhaps need more of is summits like this, which enable us the space to think, to connect, and to partner for the future. The answers are within us, so be optimistic as I am. Thank you, Tamsin.
thank you very much to Jane and to all the members of our panel, to Joost, to Jane, to Stessi, to Natasha who joined us online, to Andrea and to Sean. So let me just close our Health Innovation Summit, which I think, we had this red thread that moved through it all, which was innovation in thinking. Yes, I'm sorry, did you have your hand up? Did you want to say something briefly? We can get a microphone to you, but it has to be very brief because we're running out of time. Please stand up and introduce yourself.
Hello, my name is Mihai Todirica. I have only one short question. There are many national health systems. Do you think that some of their competencies should be transferred to European Union and have maybe one even European health agency, just health agency?
Well, I'm sure if I asked 5 people on the panel, I'd get 5 slightly variations on that, and there's no way we could answer that in a minute. But if anyone wants to take up the challenge, feel free. But Joost, go ahead.
I mean, your guess is as good as mine. I think, well, the treaty says today that we cannot do that. So bureaucratically, the answer is easy, no. Unless you change the treaty and you transfer the competences to the level of the EU, and then, legally speaking, institutionally speaking, it would be possible. We had a conference on the future of Europe. Very big conferences. I didn't see this anywhere. Nowhere. But there was a lot on mental health. There was a lot on young people, which was good, and we're taking that forward, but there was no desire. I didn't see any desire to do this. So politically, there doesn't seem to be much support for this. If ever it would happen, then I think you need to create a completely different commission, because we have very few people, actually. I think I'm talking here now a lot about, long-term care, but I think I don't even have 5 people in my own department. Now, obviously, we have a lot of support from member states. We have the important stakeholders, scientific research, so we do a pretty good show. But the idea that we would be managing, or the colleagues in DG SANTE, the health sector for the whole of the EU is pie in the sky, if you ask me. Also because the differences are so enormous. It will be very hard for us to invent a system that is applicable and useful and payable, affordable for all 27 member states, regions. I cannot recommend it today, but who knows? Next generations, things can always happen.
Thank you. I am now going to conclude because we've come to the end of our time. I just want to remind something that came through earlier today, which was during the pandemic, what we had was urgency, and that urgency created fluidity in thinking. Fluidity in the way that we approached what we can and cannot do, whether it was healthcare or anywhere else. So I want to encourage that fluidity of thinking and flexibility as we move forward, because the 3 areas we looked at today, the citizen engagement and empowerment, the green transition and aging, all require a different approach, a new way of thinking. So if there's one message I think that's come through very strongly is the pressure cooker that was the pandemic offered us that opportunity of fluidity of thinking. We will need that to approach the challenges that our health systems and our societies need to deal with in the future. So thank you to this panel and our previous panels for helping us to think through it. And thank you to you for your very active participation and engaging with these big questions. And we see you at another Friends of Europe event very soon. Thank you.
Thank you.